And with that, good morning and welcome to our 13th ever Resident Scholarly Works Virtual Summit hosted by the IAFP. I'm Ginny Flynn, Vice President of Communications, and I'll serve as your moderator for today's webinar. Unless you are the presenting resident, please mute yourself. Only the presenters should activate their video if they wish, and we hope they will. As a reminder, the Illinois Academy of Family Physicians supports diversity, equity, inclusions in all of its forms. And we hope today's webinar reflects that commitment with our culture, our values, our activities, and our behaviors. As a reminder, everyone's in listen-only mode, and today's webinar will be recorded and made available as enduring CME. Only the anonymous reviewers can ask questions, and all the questions and answers will be part of the recording. Because there's CME involved, that means we must do the faculty disclosures. The IAFP adheres to the conflict of interest policy of the ACCME and the AMA. It's the policy of IAFP that all individuals in a position to control CME content disclose any relationships with ineligible companies upon their invitation to participate. All of our presenters did submit disclosure statements, and I can report that Drs. Levitske, Patel, Njenga, Khan, and myself, Ginny Flynn, disclose no relevant financial relationship or interest with a proprietary entity producing, marketing, reselling, or distributing healthcare goods and services. And those are the remaining ones. Today's webinar will provide AMA Category 1 continuing medical education. If you are joining us live, the link to the post-test and evaluation and credit claim will be put in the chat throughout the day and also sent by email to you afterwards. If you're watching us on recorded, the link to the post-test evaluation and credit claim will be found in the video description. Click on more underneath the video to see the rest of the description and access that link. Just a couple of quick announcements. We have some upcoming events. Our annual foundation fundraiser is a day at the Chicago Sky Game. It's on our website and also with that QR code you see there. And IAFP is also the host chapter for the Family Medicine Midwest Conference in September in Naperville. And for those of you who are presenting, you have a ready-made abstract. We hope you will submit it. The call for abstracts is open until June 1st. Everything is at fmmidwest.org. And of course, your opinion matters. We invite our presenters and anyone who is watching for their own education to use the Google review and post your reviews. So how does this work? Our presenters will have 15 minutes to present. They'll get a 2-minute warning in the chat. And then our 2 anonymous reviewers who are not using their real names, as you might be able to tell, will ask questions. Our reviewers have 2 options. They can put their questions in the chat box, or they can unmute and ask. Our first presenter today is Dr. Cassandra Levitske from the University of Chicago AdventHealth Hinsdale Family Medicine Residency Program, and she will be reviewed by Drs. Meredith Gray and Natalie Manning. Dr. Levitske, if you are ready, I will stop sharing my screen. You can share yours. The clock will begin when you do, and we wish you the best of luck. Enjoy.
All right, everyone can hear me, hopefully. I am Dr. Levitske, and let me put my presentation up. There we go. Okay, so my project is on the Resident Recharge series. I call it Wellness by Us for Us. This project is in process. It's an educational, so it's not finished. And so we're going to get started here. Overview, we're going to talk about background, what we use to measure, the project aim, the intervention, timeline, next steps, results so far, because this is in progress project, challenges, lessons learned, and references. So some background, over 50% of residents report symptoms of burnout in the US, and nearly 30% report signs of depression. Burnout's been associated with increased medical errors, decreased professionalism, and early departure from the medical field. The ACGME has recognized resident physician well-being as a core requirement, encouraging programs to implement tangible support structures. So our measurement that we decided to use was the mini-res-Z. What this was, it has 4 different subcategories. The main one is a joyful workplace, which is the overall calculation of wellness that is used in this supportive work environment, work pace and EMR stress, work interruptions, and support. And the mini res shows that if you hit 80% or higher, they consider that you've hit joy or a joyful workplace. So that's just some background information for this measurement. Additionally, this is from the 2022 and 2023 mini res by the AMA. They do have some 2024 data out, but they don't have the exact numbers out yet. So this is just for comparison as a national average. No one is meeting joy, but there are some higher levels in the first category here, which is supportive work environments and work interruptions and support. And additionally, you can also see that they averaged it by question, and 4 points, which would be that 80% of joy was met in certain categories nationally: program satisfaction, values assigned with leaders, and peer support. And then this is the little data that the AMA does have from 2024 data, is that 34.5% of residents reported experiencing burnout, which actually decreased from 2023, which was 42.5. When it came to program satisfaction levels declined with each postgraduate year. So it was a 91% first year, 81% in the second year, and 80% in the third year. And burnout by training year also increased as the years went on. So knowing this data, what came when it came to our residents at the UChicago AdventHealth Hinsdale. So we actually found that 87.5% of residents admitted to experiencing some symptoms of burnout. 87.5% reported feeling a great deal of stress due to their job, and 91.7% admitted to spending a moderate to excessive amount of time on EMR after work hours. So this definitely underscores that interventions need to be made to address this wellness, the emotional exhaustion, work-life imbalance, administrative burden. And some key resident feedback just to highlight on scheduling and time management, clinical efficacy, burnout and emotional health, and encouragement for physical and outdoor wellness, as residents are often, most of their time is either in the hospital or in the clinic. Minimal to none is outside unless they're not working. So this was our data for those three categories when it came to supportive work environment. It follows about average what was shown for 2023 and 2022 on the AMA. No category is supporting and officially hitting that joy level or that 80%. However, the work pace in EMR, which is that orange column here, is the lowest, which is common trend throughout all the data when it comes to 2022, 2023, and then our data here. And then another measurement we used was pre and post lecture surveys, which was before and after lecture surveys geared towards that specific lecture, as well as a measurement to see how things progress. So our aim by June 2025, we aim to improve resident physician wellness at UChicago AdventHealth Hinsdale by implementing a two-part wellness lecture series using materials from Bridge to Better and the American Academy of Family Physicians. We measure pre and post intervention outcomes using resident surveys that included the mini res that I already discussed and post surveys per each lecture, with the goal of achieving 5% improvement in self-reported wellness indicators. So what was our intervention? This is a lecture series initially created by the AAFP and Bridge to Better. The focus is on 2 lectures, belonging and boundary setting. Some of the other sessions that you can see in the bottom right-hand corner were also provided, but were not done in this program that we measured. However, certain pieces were done by faculty members. And the Bridge to Better toolkit was developed to create evidence-based resources to promote wellness, help develop resilient, compassionate, and effective future physicians. So this is just an overview of what the AAFP provided. And then additionally, myself and the behavioral scientist at our program added our own twist and additions to this to increase and get more engagement. So what is the project timeline? So we did the measurement in September 2024. That was the results I shared with you earlier in the mini res. In October 2024, we did the self and boundaries lecture, and then we did a pre and post survey. You'll see those results. And then now we just did the second lecture this Monday in May 2025, which concluded belonging, and we have some pre and post lecture survey. And our next steps will be that post mini res Z intervention, which we hope to do in June 2025, so coming up. So progress to date. So when it came to our boundary lecture, did this lecture help me feel more confident in setting boundaries? We had 100% say yes, 16 people attended, which was great. And then overall, we asked each participant to rank from 1 to 5, 5 being the most confident, 1 being the least confident, on what they feel is what they feel is important in their lives, respecting their values and their comfort setting boundaries before the lecture and after the lecture. And you can see that there is a difference between each column, pre and post, definitely the largest increase in comfort and setting boundaries, which was great, at least for that one single lecture series. And then the second lecture we did as regard to belonging, and this is some of the verbal and feedback that we got was it was engaging, balanced, effective. Attendants loved the interactive format, and the presentation was strong and enjoyable. And this was just a quick pre and post lecture results. Do you feel like you personally can help create a sense of belonging for others in this program? It was 46% said maybe, but they're not sure how. And then post lecture, 100% felt yes, they could definitely. So we're very happy with those results. Some challenges that we had along the way is we were hoping to do the entire lecture series. I first learned about this about a year ago that the AAFP Bridge to Better lecture series was being released. Unfortunately, it was released less than a few months ago. So it was still being developed when we put the project in foot. And so we decided to focus just on 2 sessions. Time constraint wise is, as I am a 3rd year family medicine resident, I will be graduating. So we only had so much time to complete this lecture series. This is why we focused on just the 2 sessions. However, our behavioral scientist plans to include all the lecture series and add on more in the years to come. And then some challenges. So our first lecture was very well received, especially by our faculty, and that was in regards to boundaries. However, I felt and I heard verbally a lot that the residents, it wasn't their favorite lecture. And it was interesting because this lecture series was developed by residents, funded by the AFP to target residents and help them feel more well. That was the goal. However, for some reason, we weren't reaching residents, which was just the irony of the whole thing was intended for residents, but that first lecture seemed to have some barriers. And I did a lot of reflection trying to figure out, okay, how can we pivot to make sure that we're not only reaching faculty, which is important because if faculty start to pick up on some of these wellness habits, it will hopefully trickle down to residents, but how can we make sure we're hitting both? And what I really felt like it came down to was Maslow's hierarchy of needs. So what this is it shows each level of this pyramid here has different needs. And once you have your physiological needs like air, water, food, shelter, sleep, which we don't always get in residency if we just came off of night call. And once your safety needs are met, then you can go to love and belonging. Then you have esteem and self-actualization. And I felt like the boundary lecture sometimes was self-actualization or just even just a little bit too high up on that pyramid for some of the residents to really absorb and feel well. And so trying to recognize and identify where residents are at, how to help them fill those bottom levels so they can meet us at higher ones or bring these lectures down to a little bit lower need. In the Maslow hierarchy was a challenge, but one thing that we did in the second lecture was I added the plate activity, which was an activity where we wrote positive messages on every participant that was there and things that we recognized that were positive attributes in the other person to help them feel more belonged. And I felt like that provided not only love and belonging, which is that middle tier, but a safety and a need. They felt like a personal security. It was only positive things that they were getting and help them feel secure. So trying to bring it down to a lower hierarchy of need, I felt like was very important and thankfully paid off for that second lecture. Lessons learned, it's never too late to pivot, as we did for our second lecture. Resident faculty also resonated well with these lectures, so know that this is just not an intervention for residents, but faculty and everyone in the residency involved. And my third lesson was everyone likes to feel recognized and valued. These are my references, and that's the end of my slides. Are there any questions?
Well, first, thank you so much, Dr. Levitske, for the presentation. For your in progress category, I forgot to mention that. And yes, your first question is already teed up in the chat from Dr. Meredith Gray. She has actually 2 questions. Why did you decide to use the mini res? So we'll start there.
Yeah, it's a great question. So one is, as a resident physician, I have minimal to no funding and it is free. The other thing is the AMA was already using it, and I had some great data, as I showed in my slides, on what to compare on a national level for us versus, for our residency program, we already have something on a national, like how are we comparing in that? And then additionally, I did a project before on wellness, and I already had pre-data from that project. So it was just a continuation again. So it was free, it was easy. It's only 15 questions. A lot of wellness surveys are significantly longer. So it's not so much of a burden to complete this. Yeah.
Okay, and her second question asks about why the 5% increase after you collected your initial data. Would a 5% increase be statistically significant?
That's a very good question, and which is why I agree. I wasn't sure that the 5% increase would be statistically significant depending on the amount of participants, because we did have 24 residents respond to the mini res survey, and then about 16 people total, which include residents and faculty at each lecture. I just wanted to see some increase. And for me, I felt like I don't like setting goals too high. Of course, my ideal goal would be 100%. I'd love everyone to be at 80+% joy or higher. However, I think I just wanted to create an achievable goal, or something that seemed more a SMART goal. So something timely, realistic, achievable, or at least hope to achieve. Because I think when it comes to wellness, it's really hard to sometimes see momentum, or for others to see momentum, or to see progress. And it can be very defeating. Oh, we didn't get to that 10%. We didn't get to that 20%. It's not fruitful. Why even try? And I really feel like it's important to get those small goals in order. So even if we just get a small amount, the next time, hopefully that says a precedent to increase. And next time we can set a bigger goal. It's more achievable this time, now that we have some data that we can do a small piece.
This is Dr. Manning.
Hi.
Dr. Levitske, I thought you did a very nice job in constructing the intervention, in dealing with the problems of not having all the materials out from AAFP yet. And I really like the way you did your displays and your graphics.
Thank you.
An important topic, of course. Two questions. One is, do you have a planned analysis like a paired t-test, which would be able to show you statistical significance, but would require you to link the pre-test and post-test to the individuals?
So I do, so the plan is to do a t-test. However, it wouldn't be a paired t-test, it'd be an unpaired t-test. So thus I wouldn't have, because it was an anonymous survey, so I wouldn't know which individual. I know what one person said and second person said. So out of the 24, I don't know which of the 24 would belong to the second part, but I do plan on doing an unpaired t-test to get the statistical significance if wellness. So not only is it that 5% wellness was a broad category, there's so many ways to measure that wellness. One was the overall category, one was EMR flow, one was supportive work environment. And the third one's not coming to me, but there was another one. And on top of it, an individual question level. So hopefully we see some progress in one or multiple areas. But that was the plan, is to do unpaired t-test.
Good plan. For the data that you have. I know it's hard to assure people that they're anonymous if it's confidential and they worry about somebody breaking the code.
Sure.
Next question is, the narrative comments seem to be part of what influenced you. Was that formal or informal? Do you have, is there a place where you have a comments or narrative comments response on any of the assessments?
Yeah, so there, after the pre and post surveys and the mini, well, every survey that I've done, I always like to give section for feedback. And so the feedback from the first lecture, some of it was verbal and some of it was actually written, that I do have to reference from the first lecture and the section lecture. So I guess I had a mixture of both qualitatively.
Great, thank you.
You're
Nice
welcome.
job. I hope you plan to submit for Family Medicine Midwest.
Thank you.
All right, and we're off to a wonderful start. We will move to our second presentation, which also comes from the AdventHealth Hinsdale Family Medicine Residency Program. I'm going to welcome Dr. Komal Patel and Dr. Amy Strom for their presentation of a completed project. Also reviewing this one, we'll have Dr. Gray and Dr. Manning again review this presentation. I see both Dr. Patel and Dr. Strom, so when you are ready, you can share your screen and the clock will begin when you do. We wish you good luck.
Okay, give me just 1 second. I'm gonna get the screen set up.
Right. we see your slides. You're ready. We can begin when you're ready.
I'm still setting it up. Hold on. There we go. Everyone can see that? Yeah, okay. Then we can start. So our project was on implementing transitional care management billing in a residency clinic. No disclosures. This is our agenda. We'll go through the background, what we did essentially for the project, and like limitations of the project and ideas for future improvement. So a little background on TCM. I know most of us are family medicine here and are familiar with what TCM is, but our clinic did not bill any TCM visits. So just so everyone's on the same page, back in 2013, CMS created a new billing codes, 99495, 99496, that addressed the work involved in coordinating post-discharge services and increased reimbursements for physicians. TCM aims to address the period of the handoff between acute care setting and outpatient setting, aka hospitalizations to outside world, which targets populations at the greatest risk, those with chronic conditions, frailty, or multi-organ system failures, just to name a few. Another major benefit in implementing TCM is it reduces hospital admission rates, which is mainly due to communication failures and unimplemented care plans, like patients didn't get their medications on time, didn't get IR referral in time, things like that, and which makes sense that the insurance would want to pay the PCP more for that one visit versus the hospital stay. For TCM billing, discharge refers to discharge from inpatient settings such as acute care hospital, rehab hospital, long-term acute care or SNF. Discharge from ER or assisted living facilities do not count. And there's other minor criteria like, mothers who gave birth in the hospital and stay a night, that does not count towards the TCM either. This slide, during the visit for a TCM, these are some of the questions that we address. And when a patient sees you for a hospital discharge, these are some of the things we go through anyway. It's second nature to us. We ask about MedReg, we ask about labs, any DMEs, any new referrals they need, PT, OT, things like that. Nothing extra we're doing during the visit, so why not bill for it? Oops, sorry. Lost my slide. And then this slide we put together, it shows the different insurances that are accepted at our clinic, HFMC, and it's showing the reimbursement rates for the level visits 99213, 99214, and the TCM visits 99495 and 99496. And you can see that there is an overall difference in the reimbursements for the level codes versus the TCM codes. And one thing we noted from this chart was that some insurances, patient did not have any extra out-of-pocket costs if we billed the TCM visit versus they had to pay a copay with the level visits. And that's why we wanted to do this project and see if we saw a revenue difference. And one thing you'll of course notice, Medicaid does not cover TCM. Oh, so I'm having a hard time with this computer. Okay, and then this slide, just to put it in a different perspective, everything you saw on the previous slide, we just averaged out the payments after the fee adjustments for the insurances, and you can see the level codes and TCM codes, what their average payout is between all the insurances. So average level 3 pays you approximately $82, while a 99495 pays you $220, which is 2.5 times more for doing the same amount of work. And if RVUs make more sense to you, that table is there as well. And of course, depending on which CMS table your company is using, these values will vary, but just to get an idea. And some of the criteria to bill for the TCM, CPT2 codes must be billed for the TCM to be covered. And there's like a whole nother set of criteria, which just for the sake of time, we're not going through it. But some of the common pointers, like first contact needs to have happened within 48 business hours of discharge. And then the two codes 99495 and 99496 have their own time constraints, like the 95 can be billed within 14 days of discharge if the initial criteria are met. And then the 9-6, which is a higher medical complexity code, needs to be billed within 7 days of discharge. And now we'll just move on to the quality improvement project.
All right, so I'm going to start by talking about our project now that you have that background. So the main objective of our project was to educate residents, faculty, and staff on the benefits and the logistics of billing a TCM visit, and then start implementing these TCM office visits and TCM billing in our clinic. And then we wanted to determine how much increased revenue there was for our clinic after implementing TCM billing. So first, we gave a presentation to the residents and the faculty in our program about the importance of TCM, how to appropriately document one of these visits and how to bill for them. We also met with some of our clinic nurses and front desk staff to teach them about calling patients after they're discharged from the hospital and scheduling their TCM visit. We also created dot phrases for the nurses and the physicians to use in clinic just to make everything simpler. And then we collected our data from November of 2023 through September of 2024. So some of our nurses at the clinic would receive a list of all the patients that had been discharged from the hospital. And the nurses would then call the patient within 2 business days and document it in their chart. We did make this dot phrase shown here just for them to use during the phone call to make it more simple. This just includes basic information about their hospital stay, checks in on how they're doing, and then they would forward the patient over to the front desk so that the front desk could verify that their insurance is covered and schedule them for a TCM visit. We also made dot phrases for the residents and the attendings to use in clinic so that everyone had everything that they needed in their note. This is the dot phrase for HPI. It can, of course, be tweaked based on what's relevant for each patient or based on their hospital course. And then this was the dot phrase that we made for the assessment and plan portion of the note. On the right, you'll see we did include the billing codes and the CPT2 codes, just as a reminder to everyone so they don't have to look them up each time. And then the right portion of the template would be deleted from the note before it's signed.
Okay, now, so for the results. So these 2 charts essentially show the same thing. Before the TCM billing implementation, as I mentioned before, we had 0 billed at HFMC. After the project, we billed a total of 65 TCM visits successfully. 35 of those were 99495 and 30 of those were 99496. The graph on the left right here, this one, shows the breakdown breakdown of the revenue difference noted based on the level visit versus the TCM. Red shows the revenue made after the project. Blue shows the revenue that would have been made if we continue to only bill the level visits. And you can note that there is a significant difference, especially if you look at just like the total combined numbers on the right graph. We had generated $16,418 versus only $6,343 if we had only continued to bill it as level visits. This little slide shows the time frame most patients followed up in. Of the 65 TCM visits, 41 of those were billed within 7 days, and 24 of those were billed within 8 to 14 days. We can note the RVU differences if that number makes more sense to you. I included that table as well. These numbers were based off, of course, the same numbers used in the previous slide. I also have a Sankey chart in here, which shows total of like 104 TCMs that could have been billed. And of those, 65 were successfully billed. We looked into this further and noticed some of the visits were mislabeled, meaning reason for the visit may have said ED follow-up or chronic conditions when it was actually a hospital discharge follow-up. So of the 65, 57 were labeled correctly. We missed 39 TCMs. We tried to identify reasons for those. Some of them were mislabeled visits, 8 of which were correctly identified by the residents, meaning our intervention with the residents and teaching was successful. We identified 66% of the incorrectly labeled TCMs. We had 4 no-shows and there were 23 missed total. And the reason being like no phone call was documented different PCP follow-up. Patient just rescheduled so many times that they were out of the 14-day window.
So in conclusion, TCM is intended to help patients have a smooth transition from the inpatient to the outpatient setting and helps to reduce readmission rates. And at the same time, TCM saves money for the patient, but also brings in additional revenue to the clinic and the physician. Because as you saw, our clinic brought in over $10,000 of additional revenue just by implementing TCM billing over less than a year. So even though we missed billing 39 possible TCMs due to various reasons, residents were able to identify about 2/3 of the mislabeled visits, which we were really happy with and proud of our co-residents for.
One additional thing to add to our conclusion is that as a DO, we do like to mention the osteopathic principles. These are the 4 basic osteopathic principles we learned in school and residency. And I just wanted to point out that osteopathic principles were relevant for this project because TCM encourages patient to follow up with proper follow-up. It enhances patients' recovery and self-healing and health maintenance by ensuring patients have their proper medications, specialist referrals, support at home, and which essentially decreases readmission rates.
So some limitations that we found with our project were that we may not have identified all of the TCM visits or incorrectly billed them as a level visit instead. Sometimes patients were unreachable to schedule or just didn't show up for their appointment. A large percentage of our clinic population does have Medicaid, which does not reimburse for TCM visits. So that was definitely a limitation. But as you can see, we have a lot of ideas about future directions for our project and improvements that could be made. But the main things that we would want to look at in the future are how many times are we calling patients before reaching them? And are they scheduling an appointment? When are they scheduling an appointment, if ever? What percentage of patients no-showed and how do we reduce that rate? What are the readmission rates after a TCM visit versus having no PCP follow-up? And also looking into increasing patient education on the importance of TCM and finding ways to encourage them to follow up after hospital discharge. And that's the end. Does anyone have any questions?
All right, our thanks to you both. Again, Dr. Gray and Dr. Manning, you can put your questions in the chat or you can unmute and ask them live.
This Dr. Manning, a very, very nice project, and I imagine your healthcare system is happy that you are improving billing.
Yeah.
Did you do any analysis of the providers that were involved with the billing to see, is it faculty, is it residents, is there a change?
No, we didn't delve that deep into it just because most of our time was spent on just like the initial implementation. That's one of our future plans. We, our head of billing department, Marianne Harrelson, she did get back to us with which doctor billed the TCM, and it seemed like it was more of the residents versus the attendings, but we just didn't have enough data to say oh, one resident billed more than the other just because of our clinic schedule. And at that time, we didn't have continuity clinics in place either. So it was kind of erratic.
The residents also see more patients in clinic than our attendings do. So that could skew the data as well, but definitely something to look into.
Yeah.
It won't be the first time that an intervention has shown better resident performance than faculty, however. Is there, who takes over? So I really enjoyed the dot phrase. I thought that was so important to put into your intervention. Who takes over the project now? Will you all be continuing it or you have people who are taking it on for you?
I can answer. So our one of our two attendings, Dr. Kian, handles the research, and Dr. Bachhold, she handles clinical things. Our dot phrases are shared with both of them and they can edit them. So for the future residents, they will continue sharing it with them. And their plan is to at least include this TCM lecture as one of their noon lectures so they can properly teach the incoming residents how to bill, what exactly the purpose of TCM is and things like that. In a way, I guess that will be our continuity of the project. Yeah.
We're-
Go ahead. No, that's it.
We're also hoping some of the new incoming residents this summer will want to take over
Yeah.
and kind of continue the research with this project.
Yeah.
Yeah, sounds like a good idea. And the last comment is just I appreciated the osteopathic principles that you incorporated in. Thank you. And again, please submit to Family Medicine Midwest. June 1st is the deadline. June 10th, I think, and June 15th is the poster deadline. Thank you.
Will do. Thank you.
And our thanks to you both as well. And in fact, we're a couple minutes ahead of schedule. I do see that our third presenter, Dr. Njenga, is on board. Dr. Njenga, it's up to you. If you don't mind starting a couple minutes early, you can either give a thumbs up or you can unmute and say hello. And if you don't mind going a couple minutes early, we'll move on.
Hi, good morning. Just give me a minute. Let me load my presentation here.
Of course. And in fact, we're going to give our thanks to Dr. Gray. Stick around for the fourth presentation. We're going to welcome Dr. Elliott Reed as another anonymous reviewer for this presentation. And also, I forgot to mention, there is a couple things at stake for today's virtual summit. One, of course, is bragging rights, and two, the top scoring presentation in both the completed and the in progress research category will get an Amazon gift card. So there is something to compete for besides bragging rights. I see your presentation, Dr. Njenga. Are you about ready? And I can go ahead and formally introduce you. Wonderful. Okay, we're on to presentation number 3. Nothing wrong with being a couple minutes ahead of schedule. I'd like to welcome Dr. Catherine Njenga from Jackson Park Hospital Family Medicine Residency doing her completed project. And again, her faculty reviewers will be Dr. Elliott Reed and Dr. Natalie Manning again. Just a reminder, Dr. Njenga, the clock will begin when you do. You have 15 minutes and you will get a 2-minute warning if we get that far.
Okay.
Are you ready? The clock will begin when you do. Good luck.
All right. Yeah, we can go ahead. All right. Good morning, everyone. My name is Dr. Njenga. I am a PGY3 from Jackson Park Hospital. And my research project was on mental health. When I started this project, I wanted to try and see how, as a primary care provider, I can help my patients access mental health care. Especially in light of a few of the problems that I came across in our particular clinic. So in this project, I am going to touch over an introduction of the project, what are the methods I used, what I found out, and how we can apply this, particularly in my clinic. So the objective of my project was to evaluate what I, as a primary care physician, and those I work with, can do in terms of managing mental health conditions in a small community hospital setting. So the thing that I found when I was doing my research is that mental health disorders significantly influence non-communicable diseases. And those in our community are mostly things like COPD, high blood pressure, asthma. And a lot of times we have patients who come in with these diseases that have mental health disorders, but we focus more on the things that we know, the high blood pressure, the high cholesterol, the diabetes. But in the World Health Organization study that I had looked at, we found that a lot of patients who have mental health disorders have adverse outcomes in the other diseases, the other comorbidities that they have. The other thing was that primary care physicians are the first point of contact to a patient. So when the patient comes into you and you notice something that they need some help in the mental health area, how are we able to detect this earlier so that we can manage the patient better? So in terms of how to integrate mental health care, that becomes important in that a lot of times patients trust us as primary care. And so we want to mitigate things that we can in clinic before we send them out to somebody else. So some of the things that enable us to be able to do this include that we help reduce the stigma. If a patient is coming to you consistently, they trust you more. And it's better than them thinking, well, I'm going to see a shrink, like we hear a lot of our patients say. So we reduce the stigma. We're able to help take care of some of the mental health disorders that they have. It also enhances continuity of care because the patient sees one provider before you have to refer them to somebody else. So it helps enhance the continuity of care for that patient. And then it's easier for patients to get appointments with us primary care physicians as opposed to trying to get a mental health professional. We found that a lot of our patients have a hard time getting referral, not even getting referral, getting appointments with mental health providers. So this being able to integrate mental health care in primary care does help improve access for such situations. The significance of including mental health in primary care would be that health outcomes would be improved because once you take care of one aspect, the mental health aspect, the patient may be able to better understand and probably take care of the other comorbidities they have because you've reduced one of the burdens that they have. So in this particular study, I did a cross-sectional study. I started back in November and I did this up until January. Because I was only focusing in our clinic, our first floor clinic at Jackson Park, I only did outpatient and I was only able to get 16 participants. And these included both attendings and residents. I used surveys and I used Microsoft Excel to do the analysis of the data that I had collected. I did include my questionnaire in the presentation just to kind of go over some of the things that I was asking the participants. And a lot of it was how comfortable primary care providers feel with providing mental health care to patients. If they have an issue as far as referring patients, do you have the ability to refer out? And are your patients able to get the care that they need in a timely fashion? Say I send them to psychology or psychiatry, is it taking them more than 3 months to get an appointment? I also queried whether physicians found it more accessible to use the tools that we have, the PHQ-2s, GAD. Is it better for you as a physician to use this in person, online, or not at all? And then I also asked if the physicians felt comfortable dealing with mental health care in clinic by themselves. So if I was not able to refer a patient out or the patient told me that they felt more comfortable with me dealing with them, am I able to take care of them? Do I feel comfortable enough to do that? And then I also asked the physicians what would be the one thing that they would change that would help improve mental health care in the primary care setting in our clinic. So the results I found included that a lot of our practitioners, or at least 50% of them, felt that they were comfortable in managing mental health concerns. So if a patient came in and said they felt depressed, I did my PHQ-2 and I found that this patient does indeed need medication. The physician felt comfortable enough to give the medication. The physicians that I surveyed said that 73% of them felt comfortable enough to use the tools at their disposal, the PHQ-2 and GAD-7. 47% of them felt more comfortable doing this in person. So when you're doing your patient history on the EMR, we do have a section that uses a geriatric depression scale. And a lot of them said they felt comfortable using that. Some of them did state that they thought it would be easier if we had something virtual. So say when the patient gets checked in while they're sitting in the waiting area, just have them do like on the app, because there's 2 apps for PHQ-2 and GAD-7. Have them use that, and then you can tally that information while you're seeing them in their allotted slot or appointment time, and then you can go over that with the patient. 37.5% felt comfortable enough in identifying when their patient was in crisis, while about 50% felt somewhat comfortable. And 62% were very comfortable in making referrals. But we found that 56.2% of the patients sometimes were able to access the mental health services. 68% felt that it was extremely important to integrate mental health in primary care, while 50% of the primary care physicians felt that the practice supported addressing mental health care on a primary care level. The other thing that I looked at was to see if we feel this comfortable at 50%, what are the limitations as a primary care provider at Jackson Park Outpatient Clinic that make it difficult for us to do this in clinic? And the largest hindrance was a patient's reluctance to discuss mental health concerns. So we do find in our particular population, there's a huge stigma about mental health issues. And it might just be something that we probably have to sit down with community leaders to find out if there's a way to address it in this particular community. But that was the largest limitation. The other was a limitation in the amount of referrals. So because of insurance constraints and a lack of transportation, a lot of the patients had either a hard time getting to referrals that were far away, or the referrals that we could actually get them were booked out maybe 3 to 6 months. And that's not something would be good if a patient was in crisis. And then lastly, like everybody knows, family care, we have always time constraints during office visits. Insurance allots us maybe 15 minutes, of which 7 are the only that I have with a patient. So it makes it difficult to address every other thing, like their high blood pressure, high cholesterol, and then include that with the mental health. But we have to remember that this is part of primary care. So I wanted to see, okay, so what can we do to help improve mental health care within the allotted time with the patients. So I found that in my project that even though we do have the tools and the knowledge to address mental health concerns in the primary care setting, we can always improve what the role we play with our patients. One of this would be something that would obviously be kind of difficult to do, would be increasing the consultation time that we have with the patients. And again, this is pretty much it's out of our realm, I guess, because it's an administration thing, it's an insurance thing, so we may not be able to do that. So the other thing we could do is probably improve the access to specialists, maybe trying to recruit more psychiatric, psychologic nurses, therapists into the practice, or improve the referral systems. That might also help strengthen our role as primary care, who actually helps our patients access mental health. And then also the other thing as a large that could be done is advocating for policy changes that help with improving the amount of providers that are available, maybe supplementing or helping with reimbursement so that students can actually go into psychiatry or psychology. And for our particular clinic, my study would be applicable if we were able to implement a few things to make it a little bit better for our patients. We do have an EMR limitation. EMR is a little, it's undergoing an upgrade. And one of the things that we are hoping that we will get is an incorporation of the PHQ-2 and GAD-7. The EMR that we currently have actually has it has a geriatric depression scale, which can be applied, but we would prefer if we had a PHQ-2 or a PHQ-9. So we are hoping that once the EMR upgrade comes in, that we would be able to address this issue. And then the other thing that we could do in our clinic is to improve the confidence of residents as far as you have a patient who comes in, you've done your PHQ-2, PHQ-9, GAD-7, you think this patient could benefit from medication. So encouraging residents to prescribe and possibly, meet with their patients, have them come back in for probably talk therapy. That would be helpful in boosting the confidence of the residents in managing the patient's mental health concerns and thus addressing these issues on a primary care level. And those were my references. Like I said, I did look a lot at the World Health Organization. They had a really good study that they did across a few countries, and that's what I used as my primary base. And any questions?
Thank you so much, Dr. Njenga. I definitely hope we have some questions. Dr. Reed or Dr. Manning, the floor is yours.
Hi, well, I'd like to thank you for the presentation. This is Dr. Reed.
Hi.
I really enjoyed the presentation because it brings up a concern that we see in our primary care clinics every day. And to kind of figure out how within your own clinic you're able to help solve that, I think is a big task and something that is important. I appreciated how you kind of like outlined the problem. And the question that I have for you is, after you collected the data, can you talk about if there was a little bit more about kind of the intervention that was done in order to teach? Was there an intervention to teach the residents and faculty kind of about how to treat depression or how to identify it?
So honestly, I did not get that far. And I think when I first went into this, I did not think that that's the avenue I was going to go into. But I think that's a good thing that we can actually probably do after is find out how to better teach the residents, improve the confidence and teach the residents. So, but yes, I didn't go into that.
More about kind of implementing the PHQ and how to implement
Right.
the screening into the clinic to start with.
Yes. So implementation, like I said, we do have an upgrade coming, and I was aiming to wait for that upgrade to see what they incorporate and then use that to teach the residents. Because at this particular time, what we do in training is, doing the PHQ2 on our own, and then we actually input in, my patient was a score of 2 or 9. But it would be preferential if there was an actual tool in the EMR that can be used while you're seeing the patient. So that's what I'm hoping for, is once the EMR is upgraded, if that's, once that's in there, then that would be a good tool to use.
Thank you.
You're welcome.
This is Dr. Manning, and I agree with Dr. Reed. It's a very important topic, and I appreciate you tackling this. What was it that inspired you to take this project on yourself?
I have 2 patients that I've tried to send to psychology, and both of them have told me, no, we will come back and talk to you, but we will not go to somebody else. And I tried to refer them out, and the psychologist that we have, she is booked out currently, I want to say 3 months. And these were patients I was concerned about. So I have had them come back and follow with me every 2 to 4 weeks, and it's going well. And that's why I decided to do this, is I realized that there may be something that we're missing that we could probably improve in our patient population.
I'm so glad that you did that. I agree in all my years of practice that it was important to have skills in office-based counseling and know when to interact with our specialists too. So I appreciate that.
Thank you.
Did you get any narrative remarks from your surveys? Open-ended like comments?
So a lot of the open-ended comments were about time limitation. It's that we need more time with the patients, and we need better referral systems. Those were the 2 main open-ended comments I got.
Okay,
Yeah.
good. And I saw that you had given them in maybe that was a priority ladder. What's your
Yes.
total N? How many people did you?
16. Just a small sample, yeah.
Yeah, 16 pre and post. And is that of your total
Yes.
residency?
Yes. And I think I started with 25 potential, but only 16 responded.
Okay, so two-thirds response to
Yes.
your assessment. Okay.
Yes.
And the last is that if there is a way for, I hope there's somebody who's going to take on the project after you if you're leaving, to also look at whether there are additional measures that you can do in competency beyond self-assessment of comfort, because I agree it's such an important area. What is the next step plan now for this particular project?
Right now, honestly, just the EMR, and waiting with bated breath to see what the EMR incorporates. And then at that point, I think I would like to suggest, if it doesn't incorporate like the standard PHQ-2, there's apps that as residents we can quickly use. So that would be my next suggestion, is to use that, either have the patient fill it out while they're waiting, or in when you're in session with them, just have them do it quickly. So if the EMR doesn't have that, that's what I would recommend.
Are you able to personally take it on to the next step?
Yes.
Okay.
I am actually going to be leaving a little bit later in October, so I do have time that I could do this.
Okay, that's
Yes.
great.
Mhm.
I appreciate that.
Sure.
Thank you.
All right, thank you.
And also, yes, always submit to Family Medicine Midwest.
Okay.
Deadline
Sounds
coming
good.
up.
Dr.
Okay.
Manning is a huge Family Medicine Midwest proponent. And also I want to thank her myself. She has been a reviewer probably for all 13 Resident Scholarly Works Virtual Summit. She's a founding mother of this program. So I always thank you, Dr. Manning. You get off the hook until later on today. I'm going to welcome back Dr. Meredith Gray and keep Dr. Reed on for our final presentation of the day. We do have on board already Dr. Faryal Khan. I hope I said that okay. Also from Jackson Park Hospital Family Medicine Residency, doing her completed project. I can see you. And just a reminder, Dr. Gray and Dr. Reed will need your feedback at the end. Again, you'll have 15 minutes to present. The clock will begin when you do. There will be a 2-minute warning if you get to that point in the chat. And then if you hit 15 minutes, we'll ask you to wrap up. Otherwise, the floor is yours. Welcome and good luck to you.
Sounds good. Good morning, everyone. My name is Faryal. I'm a third-year family medicine resident, as Judy mentioned, from Jackson Park Hospital. I'll be sharing my screen for the presentation. Just give me a moment. So the topic of my presentation is barriers to follow-up care in academic healthcare settings. The reason I chose this topic is I believe, as a family medicine resident working in the residency clinic, I frequently observed patients missing their follow-up appointments, which often, lead to the worse health outcomes and disrupt the continuity of care. So this actually made me question or raised a pattern that why there are lost follow-up care, especially in the academic healthcare settings. And what barriers are there which are actually preventing patients to return to the clinics? To find out the reason, I conducted a research. I provided a questionnaire to the patients at the end of their follow-up visits. The nursing staff helped me distribute it and helped me clarify the details and the reasons for conducting this research. My goal from this research is to identify what factors are there from the patient's perspective, which are making us lose patients for follow-up care. So let's go into the presentation. So in this presentation, I'll be talking about the introduction, objective method, results, and the discussions. So just an overview of the things. Just give me a second, my screen went off.
We're still seeing your presentation, just so you know.
Sure, I'm not seeing it anymore, so just give me a second. Sorry about that. So the academic healthcare settings play a very crucial role in the US healthcare system, providing essential services that combine patient care, medical education, and research. And as residency clinics and academic healthcare settings, these centers cater a lot of diverse populations and are often affiliated with universities, and they often train the future healthcare professionals. So again, as we discussed before, that what are the importance of follow-up? Ensuring a follow-up care is vital to improve the patient outcomes and to reduce the readmission rates in the hospitals. We have seen when patients do not follow up advocaately, when we ask them to, they come to the clinics in a way that we have to send them to the hospitals. So effective follow-up helps in managing chronic conditions and facilitates the timely interventions, generally contributing to a better overall health. So there are often some care gaps which we can see in academic settings that can lead to the worse outcomes and increase patient attrition and reduce the treatment plans which we want to have the patient to be on. And so identifying these gaps, that what are those things that are actually not making them to effectively follow up, is essential to implement strategies that will enhance a patient retention. If we don't know what are the reasons they're not coming back to the follow-ups, how can we implement strategies to improve things? So the objective of this study is to identify the patient-specific factors associated with the missed follow-up care at the clinics, and to explore and analyze the barriers leading to missed follow-up care among the patients in academic healthcare settings and enhancing their health outcomes. This research provides actionable insights into improving patient retention by addressing specific challenges faced by diverse populations. Just a point that this research is entirely done in the Jackson Park Clinic, which is a residency clinic. So this whole research focuses on just the academic clinics, not the private clinics. So I utilized a cross-sectional qualitative analysis approach. Patients from age 18 to 80, they were randomly selected from the clinics, and 45 participants voluntarily, anonymously became the part of this research. Data was gathered through a survey given to the patients at the end of their clinic visits. And the survey has questions, around 20 questions, and with some open-ended questions in the end. And we asked the potential reasons for missed follow-up visits, addressing issues related to the clinic environment, provider interactions, and other logistical factors. So after the data was collected, I applied a thematic analysis to the data I gathered to analyze the data. Clinic staff explained the survey to the patients to ensure that they know what they're doing, and comprehension and participation, as I mentioned, was voluntary and anonymous. So the main data I got from the questionnaire was, I saw that out of 100 patients, 100% patients, like a 45 patient panel, I found out that 55.6% of the patients actually have chronic health conditions. And out of those patients, 25% close is actually missing their appointments. So that's a big number. Patients with diabetes, hypertension, stroke, chronic headaches, if those patients are not following up, you can see approximately half of those patients are not following up on a timely manner. So that's a big number. So the questionnaire asked about, specifically a direct question about with the patients, that how often are you getting reminder calls before the appointment, via text, via cell phone, or via a phone call. So 43% of the patients actually said that they were reminded once. 37% of the patients said that they got multiple reminders. And out of them, 18% said that they actually got no reminder. So no reminder was received to them either by a text or a phone call. So again, 18% is a big number, especially if you believe that 50% coming with chronic conditions, 25% of them are missing appointments, and I believe out of 18% from them are not getting the reminder calls. So we asked the direct question, the reasons for missing the appointments. So as you can see that 18% of the patients said that they had transportation issues. 12% admitted that they had some scheduling conflicts, like either they were not able to make the appointment with the same provider, or The day they wanted to come, they didn't have openings that day, so they had some scheduling conflicts. 37% actually said that they had no issues reported. 18% said that there was no follow-up information provided from the providers. So again, that part is missing, that after the clinic visit is ended, 18% of the patients said that they were not provided clear instructions that when to return for their follow-ups. It's either by the provider itself or it's either by the front desk staff. So they were not sure when to make an appointment for the follow-up. Out of them, 12.5% said that they had some insurance problems. So these were the potential reasons everybody mentioned for missing their appointments. One important thing we find out during the questionnaire survey, we ask a direct question that how important is for the patient to see the same provider, same resident, same attending when they come to see us in the clinic. So we know that interactions with healthcare providers are a significant pivotal role in shaping the patient retention. Factors such as turnover among resident physicians and inconsistency in care delivery were directly correlated with decreased patient follow-up rates. And the way we found out is that we asked the patients, how important is it for you to see the same provider? So they said that 75% of the patients said it's very important for them to see the same resident, the same attending they come each time to the clinic. And 25% said it's not that important for them, it's somewhat important. But a big number said that they really want to see the same provider, same attending every time they come to the clinic. We ask again a direct open-ended question from the patients that what is the single most important factor that you believe that will make your follow-up care more accessible? So out of them, 31% said that we want a consistent provider assignment when we come to the clinic. 12.5% of the patients said that we want improved communication, so better and clear instructions at the end of the follow-up visits, that you have to follow up in 1 week or 4 weeks or in 3 months, maybe in a handwritten or like a printed document to let them know when to return, either by the provider or again, either by the front desk staff. 56% of the patients, very important, said shorter wait times. So this pattern we have seen in residency clinics, that a lot of patients have reported longer wait times. And that is again a big reason for not following up consistently. Because probably if they come to the clinic, they have to take a half day off from work, and sometimes it takes much longer for them. So 56% reported that shorter wait times would actually enhance the follow-up care for them. So just a result, and to summarize what I found from that study, out of 45% patients that were surveyed, 56% have at least one chronic medical condition, and we see a pattern that 25% had actually missing their follow-up appointments. Regarding the reminders, only 37% of the patients getting multiple calls, 18% actually reported receiving no reminder calls. And the barriers, the most important barriers to the follow-up care, that included the transportation issues, scheduling conflicts, lack of provider follow-up instructions, and insurance-related problems. And notably, 37% said they had no reported barriers. And when we ask about how to enhance the continuity of the care, 75% felt that it was really important for them to see the same provider, while 25% said it's somewhat important. So generally, to improve the follow-up care, patients most frequently suggested shorter wait time, 56% said that, and again, consistent provider assignment and better communication. So again, just to summarize things, that maintaining continuity is very important, especially for quality primary care. Finding out the reasons for patients not following up is really crucial and important to strategize and to implement things. However, the factors that lead to these things are not very clear. So that's why we found out those reasons. And this is study focused on the areas of improvement and follow-up care in academic healthcare settings. So generally a focus on long-term patient relationship, finding out the reasons will foster some great trust and will encourage the patient on the timely follow-up appointments. These are very important for the continuity of the care and to reduce the healthcare burden with patients going to the residency, the emergency in the emergency clinics. So there were some limitations to that study as well. The study, the size of the patient sample was limited, 45 patients, which may not reflect the broader patient population and their ideas. And it's a single center data, so it was conducted at one academic clinic. So we cannot generalize these findings to other settings like rural and private practices. And the responses given by the patient were self-reported responses. So they may be subject to that, like the recall bias or some social desirability bias. So just a quick conclusion that most patients in this study valued seeing the same provider and shorter wait times as a key improvement. Reminder systems were inconsistent, and common barriers included transportation and lack of follow-up instructions. Improving communication and access may help reduce missed appointments and enhance the continuity of the clinic, and possible areas of improvement to boost patient retention in these clinics. And then we can do some longitudinal studies in the future to better provide some insights and to see if our implying our strategies actually working or not. So what's next with this thing is in the clinic, we are trying to implement a standardized reminder system to improve follow-up care. I have not personally started to work on that, but that is something I can do. And with talking with the front desk staff and generally the attendings and residents, and to remind them to implement a standardized reminder system and how we can do that to improve the follow-up compliance. Enhance what really want to enhance is the provider communication to ensure patients clearly understand follow-up plans, strengthening support and services to address barriers such as transportation and insurance coverage. We want to have a staff clinic assigned for this task to find out if some patients have transportation issues, how we can help them come to the clinic, and then if some has insurance coverages, excuse me, how can we work on that part to enhance that. Another important thing is reduce patient wait times by limiting teaching discussions during clinic hours. Usually as residents, we see the patient, we go present it to the attendings, and then we discuss it with them. Sometimes it prolongs the wait time for the patient. So another strategy is to reduce the direct teaching during the clinic hours and to implement the teaching more in the break time or the lunch time or after the clinic, we can discuss the patients. With the goal, we can conduct a larger multi-center study to validate these findings and to improve the system-wide improvements. So that is my presentation, and that with the goal of this, that improve follow-up one patient at one time. Thank you.
Thank you, Dr. Khan. First, just a point of clarification. When you mentioned the patient wait times, did that mean their time spent in the waiting room, or was that the time it took to secure a follow-up appointment?
The total time. So the time being outside, waiting to be roomed, and then seen by the resident. So it's a total visit time for them.
Okay. And then Dr. Gray submitted some questions to me in the chat. She asked, it's not clear patients surveyed actually had any missed follow-up appointments. Rather, they may have answered questions based on potential reasons they might miss an appointment. Did you consider a potential manner in which to only survey patients that had a history of missed follow-up appointments?
No, this questionnaire was given randomly to the patients. It's a randomized study. The patients were not selected. So the patients I was seeing in the clinic, I was distributing with without knowing if they are good with the follow-ups or not.
Great. I'll see if Dr. Reed has any questions she'd like to ask.
Dr. Khan, thank you. That was a very nice presentation, and I think you really were able to uncover some of the potential barriers that people have to seeking care, which is important, like you outlined. I had a similar question, and I just wonder if there might have been a way to target the people who had missed appointments, to have like kind of cleaner data about those patients in particular and why they're missing appointments. But I think that you addressed that already.
Sure.
Another question on the survey, was there an area for comments or kind of open-ended area? So in case there was some other barrier that they may have had, they could have documented that.
Sure. So in the last question, number 20, I left an open-ended question for them to if there is any other reasons that they were there. Out of the 45 questionnaires I got, I see only one patient actually wrote down that they were traveling outside to a party or like somewhere outside the states, that they were not able to make the appointment. But apart from that, I felt like the questionnaire addressed the main issues they had. So a lot of people actually left that blank.
Yeah, and you were able to come to a lot of conclusions and actually many different areas of potential improvement. If there were one that you could, and each one, it seems like a project in and of itself. If there was
Yeah.
sort of like one area that's really important to you to be able to focus on, what would that be?
For me, I think two things for me are really important. One is the shorter wait time, because I feel like when we as residents go see the patients, they've already spent like 30-40 minutes in the room. And I've been trying to find out that what is the reason that taking a long time for them to room in, do the vitals, put the charts and everything. And then after that, when we see the patients, we go present to the attendings. So that kind of like expand the visit for them a lot. So that's why a clinic strategized one thing, that residents and attending see the patients together at one time. That will also reduce their time. But also, we are also trying to work on the front desk. Once we see that when the patient is there, I personally go myself to the front desk and find out if the patient has been roomed in yet or not, and why is it taking long time. So sometimes I feel like there are a lot of patients, they have staffing issues as well. But that is something definitely that can be worked on.
Yeah. How many patients are you seeing normally in a half day?
We see about 5 to 8 patients, depending upon how many residents are in the clinic. If there are 2 residents, then probably we'll see like a 8 and 8. But if there are 3 or 4 residents, that we have to equally divide it.
I see. Thank you.
Sure.
And I would like to thank all 3 of our reviewers and all 4 of our morning presentations, definitely focusing a lot on continuity of care and comprehensiveness of care and of physician well-being, all that are important core tenets of family medicine. That's going to conclude our first block. I did put the link to the CME credit claim again in the chat. Just a reminder, you'll need to indicate which presentations you viewed. Chances are I'm the only person who's going to see all 14 today, but please claim credit only for the ones that you viewed today. A reminder to our 3 guest reviewers to please submit your scores and comments to me as soon as possible. Those scores and comments will be shared back with each presenter individually, hopefully by end of day tomorrow, and they'll also get a link to the recording. The recording for the entire event will be posted on our YouTube channel as soon as it's ready, probably at some point tomorrow. That is it for our first block this morning. We will return live for the next round with 2 presentations starting at 11:20 a.m. Thanks to everyone. All right, and welcome to the second block of our Resident Scholarly Works Virtual Summit. I'm Jenny Flynn. I am the Vice President of Communications at the Illinois Academy and also the moderator. Unless you're the presenting resident, please make sure you are muted and your camera is off. Only the presenters should activate their video cameras. But first, this is a CME presentation. all of our audience is in listen only mode, and this event is being recorded and will be made available as enduring credit. Only our anonymous reviewers can ask questions of the presenters, and the questions and answers will be part of the recording. Because there is CME provided for today's webinar, I must do the faculty disclosure statement that the Illinois Academy of Family Physicians adheres to the conflict of interest policy of the ACCME and the AMA. It is the policy of IAFP that all individuals in a position to control CME content disclose any relationships with ineligible companies upon nomination or invitation of participation. For this particular block, our physicians, Dr. Tucker and Dr. Sineda and myself, Ginny Flynn, disclose no financial relationships or interest in a proprietary entity producing, marketing, reselling, or distributing healthcare goods or services. This is accredited by the ACCME, and to claim credit, you will claim credit for each presentation that you view. There's a total of 3.5 credits eligible, but that would be if you saw all 14, and chances are I'm the only one who's going to see all 14 today. Oops. With that being said, I will put the link to the credit claim, or you'll complete the evaluation and be able to download your CME certificate for those of you who are watching live. For those of you who are doing this as enduring material on our website, the same thing, you can find the link to the post-test and credit claim in the video description. So below the video, click on more and see the full video description and the link to claim CME credit. Just a couple of quick announcements about some upcoming events. We have our upcoming foundation fundraiser on August 23rd, Chicago Sky versus the Connecticut Sun WNBA game. This will be our second time. It's on our website, and also that QR code will take you right there. And just a reminder, Illinois hosts Family Medicine Midwest this September in Naperville. All of our residents who are presenting today, you are absolutely encouraged to submit that for our call for abstracts. It's open till June 1st, and it sounds like you probably have a great abstract sitting on go after today. And you can find that at fmmidwest.org. Again, deadline is June 1st. And you can always review us on Google. This will be sent to you as part of the follow-up email after the presentations today, or you can use the QR code. It helps other people find us as well. That being said, I want to welcome our two guest reviewers. We have Dr. Abby Lockhart and Dr. Connor Rhodes. As you can imagine, those are not their real names. They're busy physicians working in Chicago ER and Chicago Med. For our presenters, you will have your slides ready on your desktop and be able to share your screen. Then the clock will begin when you do. When you have 15 minutes total, and when you hit 2 minutes remaining, I'll put a warning in the chat. And if you hit the actual 15 minutes, we'll ask you to wrap up so we can stay on schedule. And then our two guest doctor reviewers will pose questions to you. They can either unmute and ask them verbally or submit them in the chat box, which I'll read aloud. Just what's at stake today? Well, first, bragging rights, of course. And then the top presentation in each category, completed projects or research in progress, will receive an Amazon gift card, which was donated by Healthcare Associates Credit Union, who's been a longtime partner with the Illinois Academy of Family Physicians. That being said, I mentioned we have two presentations in this block, and I do believe our first one is ready to go. So I am going to welcome Dr. Trisha Tucker from the Hinsdale Family Medicine Residency Program. Dr. Lockhart and Dr. Rhodes are your reviewers. Dr. Tucker, when you are ready, if you can share your screen, we'll make sure we can see you and hear you.
All right. Let's see if this goes well like yesterday. Can you hear me?
We hear you quite well, and your slides are now visible. So we wish you luck, and the clock will begin when you do.
Okay. So my presentation is on Parenting 101, Anticipatory Guidance for Residents and Our Patients. This was a QI project I did for our residency program. So why did I choose Parenting 101? So a lot of the patients that we see at our clinic, even though it is a family medicine clinic, is probably almost 50% children. And a lot of the residents coming in have different exposure to parenting skills. So we all get the medicine skills in medical school, in terms of illnesses, how to treat them. But a lot of the information that you will need to give parents anticipatory guidance, like what they should do in certain situations, or if they're meeting certain milestones or things like that. Our tips and tricks usually you learn through parenthood or life experience. Myself, I have 2 children, so this was a passion of mine. So my goal was to improve anticipatory guidance for early childhood visits. So there's just, first thing I did was like gather varying confidence levels in counseling parents on specific routine topics such as breastfeeding. So are they able to counsel patients on difficulties with latch, oversupply, undersupply, feeding positions, and the amounts that they need, formula feeding, food introduction, like how do we introduce allergens to children, teething, sleep, and then their comfortability discussing postpartum depression and anxiety. So, like I said, there's an inconsistency in medical school training and exposure throughout life. So this is just like the beginning intro slide. That's my daughter on there when she was 6 months. But this is essentially why I did the project. My goal was to raise confidence in residents that they're more likely to engage in conversations and ask the appropriate questions that maybe parents don't know they have questions about, to help overall care for both our patients and our parents. The methodology I did was I did an initial survey that was sent out to all of the residents, and I asked them to rate their confidence levels in the various topics. So it was rating confidence levels in counseling parents on feeding in the first year of life, sleep, milestones, behavioral modification techniques, teething, activities, hygiene, and entertainment options, like how to entertain children at various ages. And the confidence levels were rated 1 to 5. So 1, not confident at all counseling the topic, and 5, confident and able to both address and answer various questions our patients might have on this topic. The response data was collected and used to determine the lecture topic. So I did a lecture series based on what people felt least comfortable talking to our patients about. So here's just a picture of the questionnaire. I also threw in, are you a parent? Because that played a big role in the residents that were parents, played a big role in their confidence, which majority of my co-residents are not parents. But those that were feel a lot more confident, obviously, discussing these things because they've gone through it. So the presentation was a 2-part lecture series. It covered the topics residents felt least comfortable counseling in. And I also provided a hands-on component to my presentation where I brought in various different breast pumps and showed them how they work, because a lot of times we're telling patients to pump, or we're saying this stuff, but we don't understand, or people, if they've never done it, don't understand the time that goes into it, how to clean the equipment, what are the different kinds of pumps, as well as different equipment that babies may need, especially for, like I said, our residents who've never had exposure to it. So here's just an example. I went over feeding positions. I went over the different types of pumps that they could be using, as well as supplemental nursing system, because a lot of people don't know about that one. And then, these are just examples of slides. A thing for, because we are an osteopathic residency that we talked about as well was condylar decompression. So it's an OMT technique that we could do in the office that will help improve cranial mobility, that actually has been shown to help improve latch and sucking. So especially when babies are coming through the, birth canal, different areas can have restrictions because of that. So there are techniques we could do in the office to kind of help baby with latch if that's a difficulty. Here's just another slide I have when we talked about food introduction, different ways to encourage baby to eat. And the results overall, the confidence levels pre-survey, this was just looking at a global of the topics we talked about. The pre-survey average is 2.79, post-survey average is 3.88. So it went up a whole point in people's confidence levels. Overall confidence in breastfeeding and equipment pre-survey for breastfeeding was 2.56, and pre-survey for equipment understanding was 2.44. And as you can see, those also both increased by 1.32 and 1.44. So increase, and I'm really passionate about breastfeeding in terms of counseling our patients on that to encourage breastfeeding. And if we do counsel them on these things and know these topics going into our experiences, residents and attendings, then we can really encourage our patients to continue breastfeeding. So let's see, and this is just another example of where we were pre-survey and post-survey. So pre-survey is blue, and then post-survey is red. So the first year of life, overall confidence went up. So you can see that in each category, the confidence really went up after the presentations. So breastfeeding equipment was kind of where we saw the biggest one, and that's where I had that hands-on portion where I passed around breast pumps and we talked about how to use them. These topics I didn't have enough time to cover in my presentation, but even then, just slightly addressing the topics did raise confidence as well. Overall, there was an increase in confidence levels. The feedback received from the residents indicated that they felt the presentation was needed and beneficial. Many of my co-residents felt this should be something that we do for the first year residents when they come in. The survey also made it apparent that there is a need and want for more education on anticipatory guidance, especially because I feel like we focus on a lot of the medical aspect, but a little bit less on the counseling, that especially in family medicine, because we cover such a broad range of ages. Some limitation to this research was the ability for residents to attend. So some residents only made one of the presentations, or versus the other. So they could have been post-call on 12-hour shifts, admitting patients, vacations, etc. And then as well as survey participation, how many of them actually responded to the survey, because a lot of times we have a lot of emails, so that limits also some of our numbers. Future projects could be to continue presentations yearly and see if confidence increases with repeated lectures from first to third year. Compare based on gender, on year, repeat survey at the 6-month mark, and see if there was improvement in their confidence. Compare parents versus non-parents, things like that. And that's my presentation.
Thank you so much, Dr. Tucker, and congratulations on your adorable daughter. Actually, the IAFP does do some work on new physicians and new parents information. So that's another topic if you're interested in staying active with the Academy. We do love to do webinars and in-person education on balancing physicianhood and parenthood simultaneously.
Yeah, I have 2 kids.
Oh! And yes, we have 2.0 level 2, because we have several of our presenters who have welcomed their second child since we started the series. So I'll be sure to follow up with you. Thank you so much for your presentation. I'm going to ask Dr. Lockhart and Dr. Rhodes if you'd like to either unmute and ask questions, or you can submit them through the chat.
Dr. Rhodes, can you hear me?
Echoey, but I think you're okay. Give it a try.
Okay, so little known fact, Dr. Connor Rhodes is actually a DO and not an MD. So thank you, Dr. Tucker, for your presentation and including an osteopathic element of that. And I like what you did, and it's great, but did you think about providing other resources for your residents that don't have children of their own to learn how to give better anticipatory guidance?
Hold on, let me find you guys again. Where am I? Can you hear me?
I can.
So this presentation was given to, it was made for my residents that don't have kids. That's why I did it.
Yeah, but what happens when you're not there? How do residents that don't have children continue to get resources? Experience is the best educator when it comes to that kind of anticipatory guidance. But did you think about other ways that you can help those residents that don't have children of their own get the support they need?
Yeah, so I've actually been trying to push my residency program, and I've got a little bit of pushback on it, trying to get them to incorporate my lecture to the first years when they first start residency, because we have this orientation, or incorporating it into a maybe like once a year lecture that's given. So I am trying to give them my PowerPoint, especially to my attendings that have children, to kind of continue it, because I do think that, from my experience of seeing anticipatory guidance given from people who don't have kids, there's a lot of lacking there because they don't have that experience of tips and tricks, or just things like you said, you just get from life experience. So. Did that answer your question?
Yes, it does. But how are you going to deal with the 17-year-old with a parent that needs some guidance on how to deal with their 17-year-old?
So my presentation was focusing on the first year of life, like childhood. So I think that could be something that maybe people can continue doing with different age groups. I can't speak to what it's like to have a 17-year-old. However, I think that the amount of visits you have in the first year of life is more significant than the amounts you have in adolescent, in terms of you're there so often, that I feel like there's more direct recommendations you can give, whereas teenagers are kind of, it's not as, every kid's different when it comes to the advice you may give. So I'm not sure how I would do that, but I think that's a great project for somebody else to do. My kids are 3 and 11 months, so that's my expertise.
Thank you.
Let's see if Dr. Lockhart has any questions for you.
Yes, I do. My first question is, can you go into a little bit of detail over what specific topics you actually addressed in your 2 lectures? Because you talked about how you had a list of topics and comfort level, but I'm not as clear as what topics were actually covered.
Yeah, so let me see if I could pull up the initial one. So I did a lot on breastfeeding. Let me see if I can pull up the PowerPoint I talked about. I just didn't include my whole PowerPoint in the, let's see. I think it's on my, I put it on Google presentation, so I might not have it on here, but let me pull up my other PowerPoint to tell you exactly which ones I went over. So I went over feeding in the first year of life. So specifically, I talked about, a huge portion was on breastfeeding and the different types of equipment that go into breastfeeding. So pumping versus, breastfeeding in general, how to counsel them on latch, different issues with latch, such as, flat nipples, inverted nipples, difficulty with latch, as well as tongue tying, if that really plays a role in certain things, because sometimes it doesn't. I went over colic and how to manage colic, as well as giving them resources that they can give if they feel like parents are, stressed out with colic. There's a specific hotline they can call as well. I went over sleep milestones. Specifically, I helped them with amounts too. We went over teething, what teeth come in first, what teeth come in next, a kind of guidance on how to help with teething. So I think the only things I didn't touch on were behavioral modification and entertainment. So I really went over a lot of the milestones, like food introduction as well.
And then my second question is about the confidence surveys. When, in relation to the lectures, did you get the data from?
So they were given, I think, about a few weeks after it was given. So I
And-
could have done like a few weeks after and then 6 months after, but I just did, I think, a few weeks after.
Okay, thank you.
And I'll add my thanks as well to Dr. Tucker for your presentation kicking off this block. I do believe our second presenter is here and ready to go. So Dr. Lockhart and Dr. Rhodes will be on duty once again. Let's see here.
Thank you.
Oh, thanks for being here, and feel free to stick around and watch our next presentation. Dr. Sammy Sineda, if you want to share your screen, you can. And we'll make sure we can see you and hear you. Dr. Sineda is joining us from Jackson Park Hospital Family Medicine Residency Program, and she's got a completed project to present to us today.
Hello.
Okay, I can hear
It's a
you.
he.
Oh, I'm so sorry. I didn't get a chance to meet you before.
It's okay.
I apologize. Now I can see you and I can hear you.
Hi, everyone. I'm Dr. Sinada from PGY3 Jackson Park Hospital, Chicago, Illinois. Let me just share my screen. Can you see the screen or not yet?
Not yet. Depending on what you selected, you might need to do new share or it share entire screen are usually the best ways to get directly there.
Okay. Can you see it now?
Still seeing just you. Let's see if you click on new share, perhaps.
Share again. Okay, sure.
Let's see that the green button underneath the video. Now, here we go. Okay, you are up and the clock will begin when you do. Good luck to you.
All right. So the project we have done that we're going to present today is the title is Medical Training and Evolution of Resilience. It was about studying moral distress and its awareness, prevalence among family medicine residents. Basically, with the current work that is being underdone in the academia and in the clinical sciences, in trying to underscore and focus on and understand the core of the phenomenon of physician fatigue, burnout, dissatisfaction with practice, and how it's being affecting the current context of the medical practice in the US and elsewhere. There has been extensive work and extensive focus as of recent times on the concept of moral distress, potentially as a precipitant of all of these issues in the future. What is moral distress? Basically, it was first coined by a philosopher. His name was Andrew Jameson in one of in a seminal work that was in the 1984 in his book The Nursing Practice. At the time, he defined moral distress as the agent, or at that time he studied it among nurses in teaching hospitals all across the U.S., but generally it was applied to all medical practitioners. But it's the agent or the practitioner being practicing medicine in a way that is in conflict with their own moral view and moral and worldview and moral focus, due to hierarchical constraints or due to systemic pressures or due to things that basically stem from outside the practitioner's own ability or control. And when all these factors come in conflict with the moral view, and the physician is having to practice, the practitioner has to practice medicine in a way in such a conflict, over time, it cannot be noticed at first. It might be in a way subjectively in the subconscious of the practitioner, but this can be the precipitant of later on physicians and practitioners having overall this aversion to the practice of medicine in whole. The foundations, as I said, first coined by Andrew Jameson, but we can trace this all the way back to Michel Foucault in the 1963. His work, the evolution of the clinic. Basically, he had coined also the term or the medical gaze, in which he tried to understand the power differentials or the power balances that come into the practice of medicine, and how physicians at that era of the 20th century, there was a shift from the humanistic view in medicine, trying to move towards a scientific, more objective sense. And that kind of sidelined a lot of the ethical foundations or the ethical aspects of the practice in a way. His view was that the medical gaze is like how the physicians or the practitioner traverses the human or the patient and goes into the illness, trying to understand it beyond the personal, more deeper aspects to the patient. All of it is just simply ways to try to understand how we try, in a way, try to practice medicine in this modern sense with all of the scientific evolutions and then all the hierarchical developments and all of that. And that results in what currently is happening, basically. Why the context of family medicine? Moral distress has been studied in like internal medicine amongst internists. It has been studied extensively among surgeons, anesthesiologists, but there have been scarce view or focus on it when it comes to the context of primary care. The primary care and the primary care physician being the first line for the patient, or the first person the patient encounters when it comes to his need, to his medical needs, his medical care, to his issues. And this goes even beyond simple disease pathologies that are like physiological in nature. The physician, the primary care physician, has to deal with aspects of the patient that goes beyond their personal lives, issues, psychological well-being, like satisfaction. Just generally, the state of well-being of the patient whole is the focus and the zero of the medical practitioner in the context of primary care. That results in exposure to a lot of problems like socioeconomic disparities that are plaguing communities, like hierarchical and systemic factors that result in problems in a community sense. The Jackson Park Hospital is located in Southside Chicago, and we serve a population that is quite underserved, has somewhat of disparity in access to medical care. The study was basically a pilot study. It was done amongst the family medicine residents in the hospital. The kind of the unique nature of the hospital itself allows for this to be like a very rich study with very rich outcomes from it. How did we go about doing the methodology? We administered the revised moral distress scale, which is the one that was revised to be applied for in the context of the medical practice and the medical practitioners. We have around 19, including myself, but the sample size was like the 18 residents available. Of those 18, I had 12 respondents, around 66%. And then we interpreted the results after in a thematic way and a quantitative structured analysis. We had of the respondent demographics, females were 7, males were 5. Those who come from population underserved in medicine, around 50%, underrepresented in medicine, my apologies. 5 were under 30, 7 were above 30. This is, in this slide, you can see the moral distress scale revised is a 21-item question. And this is these are the questions that were administered to the residents. It is answered by its statements that are the practitioner is supposed to look at and then kind of provide from 0 to 4 the degree of distress they kind of encounter with whatever context of the statement is. 0 being no distress at all, and 4 being the highest distress. We can go over a few questions here. Just for example, you can see the first question. For example, the first statement: feel pressure from others to order, facilitate what I consider to be unnecessary tests and treatment. Another one is like, follow the family's wishes to continue life support, even though I believe it is not in the best interest of the patient. Another one, continue to participate in a care of a hopelessly ill person who is being sustained on a ventilator when no one will make a decision to withdraw support, and so on. These are not ordered according to how the scale was administered, but according to how the degree, like what the answers were, as you can see in the plot next to it. When it came to the demographics, there was no, we could not find in the data any like correlation like that had any that was statistically powerful or significant between the residents' racial or ethnic background, as you can see here. But we did notice that there was a correlation between the overall distress levels were lower in those who were of a higher age, although the statistical power was not as powerful. P-value was 0.222, as you can see. The thing that was interesting after we looked at the data when we administered the scale was that most of the issues that the residents had, or most of the statements that the context that represented the highest degree of distress were when it came to end-of-life care. And it does make sense, being a very sensitive issue. A lot of different values come into play here. Physicians of different backgrounds have different values, respect with the values of the patients, the families of the patients, and these can, and then the practice itself, how the guidelines are structured. It results in all of these clashing different factors, and it was the item that had the highest distress when it came to residents. All of the questions that had to do with end of life care. One thing that was noticed, though, I would say is we noticed that when in the field of bioethics, when we had clear like agreed upon consensus when how to the practice is supposed to be conducted, what is the best actions the physicians are supposed to take in certain areas. Even when it came to end-of-life care, when it was clear and consented upon what is supposed to be done, there was a decrease in the scale of distress that the residents had expressed. The qualitative themes that can be parsed through this, basically the tight hand and the resource limits, which is the major, as Jameson had underscored in his work, how the practice can come into clash with systemic factors. And these can go all the way from the patient's wishes and the family wishes regarding to patient care, all the way to larger factors that has to do with guidelines that come from official authoritative sources. The emotional burden of the visitor bans, the low value testing mandates, the mentorship and peer debrief as buffers, were all themes that we had kind of anticipated going into the study, but there was somewhat, we did not expect how, the degree of the distress that was represented in certain areas, and we didn't especially anticipate how the causes that, or when we noticed the correlation between what reduces that distress and that was the interesting part here in the study when it came to the residents in training. And we have to keep in mind also, being a physician in training is different when being a physician practicing medicine on your own, like as an independent agent. So all of this comes into play here.
You have about 1.5 minutes remaining.
No problem. The main thing that came out of the interpretation of this study was after noticing all of these factors that had resulted in the distress in the residents and what had correlated with the decrease in the distress, is trying to understand what can be done about it. What is the next step after knowing, for example, what's happening here? And of course, this study is a pilot study, has been done in one setting. This is the limitation of it. When this study can be generalized over like multiple residency programs, multiple areas, geographic areas that serve different populations, we can have a better view of this. But of the things that we notice that can be of value to the residents is having like ethics and reflection seminars, monthly moral and distress rounds, mentorship dialogues on virtue, annual policy audit with the residents. If we have a structure in place in medical training where ethics and humanities become like a core part of the whole like project of medicine, that can result in involvement of the resident and the parental practitioner and the medical training physician in a way that can result in a buffer against all of these issues, and can result in a way that we can evolve to be able to become resilient in the faces of these constraints, these problems, these distresses, without having to eventually deal with it on our own later on in practice, unaware of exactly what we're supposed to do. And that can result in eventually, hopefully, as we can see from the recent works, a decrease in the degree of burnout, physician dissatisfaction with the practice, and the degree of, like, it's kind of crazy how much physicians are choosing to leave medicine behind as whole. And all of these are issues of severe, like, effect to the patient care in general.
Hey, Dr. Sanada, your time has expired. Perhaps you'll be able to cover some of your remaining slides and your answers to your questions. I do know Dr. Rhodes has a patient on deck in a minute. So Dr. Rhodes, if you have any questions, please ask that now so that you can not keep your patient waiting. See if Dr. Rhodes is still here and can either unmute or there he is. Hi.
Hello, can you hear me now?
Yep, gotcha.
Okay.
We can hear you.
So first of all, thank you for this presentation. This is a huge topic, and I think you maybe tried to swallow too much all at once, but it is a very important topic, and I thank you for that. And you make some good recommendations towards the end of your presentation. Have you been able to implement any of that at your program?
Not as of yet, but we're working on it, yeah.
Okay, thank you.
Thanks, Dr. Rhodes. And good point that I don't think any of our TV doctors have ever been identified as DOs. So that's something for me to look into, because we certainly have a lot of DOs in our in our membership, but I don't know if Chicago doctors or TV doctors are ever identified. Dr. Lockhart, do you have any questions for Dr. Sanada?
Yes, I just wanted to ask two questions. The first one is you said you assessed you did thematic analysis. Was that based on just which items in the screening tool, the moral distress scale, were more elevated, or how did you actually do that?
Actually, that's a very, very good question. Yes, that how we went about doing it. But the first when I first structured the design of the study, there was supposed to be amongst the group of residents who had responded a selection that I can go over an interview with them. The semantic analysis was supposed to be more rich and more it has more like data that we can gather from it if eventually like had implemented the design that way. But for the objectivity of the study, we relied more on the scale at this point instead of going for the interviews as well. But that's a really good question, yeah.
Okay. Thank you so much for clarifying. And then the second question, it was based on some of your overall results. You had mentioned that there were some items that, like ethical guidelines, help decrease distress. How did you assess that?
So you can from the items themselves, when for example, if we at the end of life of care being, I'll take that as an example, being the prime distress causing theme here. If we have, like, for example, in medical ethics, we have clear understanding of the patient's agency and the patient's if the patient desires medical care or not, if the patient desires a discontinuation of his care and undergoing, for example, like the hospice, or if the patient would like to undergo aggressive treatments. The fact that we already have consensus, we already understand the patient has full agency over those decisions, despite the fact that the topic can be very sensitive and highly like has a lot of debate going into it, then the distress was less, or the response at least conveyed less distress in that when it came to that context. But when it came to issues within the same like context of basically end of life, for example, and there wasn't any clear consensus of how to how we're supposed to act, and each case by case basis was supposed to be the analysis focus, then the distress would be more. So it was from within the items themselves, what was the issue exactly, and what was the clear consensus among practitioners of how to undergo any action at any point. That's how we noticed the difference.
Okay. Thank you.
No problem, yeah.
And I'll add my thanks to you, Dr. Sanada and Dr. Tucker, for your presentations, and to Dr. Lockhart and Dr. Rhodes for their time. That concludes our second block. It's a short block, but we will be back at 2 p.m. with a jam-packed third block with 6 presentations. So enjoy a little break, and we'll hopefully see a lot of you back here at 2 p.m. All right, we have a very busy afternoon, so I'm going to go ahead and get us started. Welcome back to the third block of the Resident Scholarly Works Virtual Summit. I'm Ginny Flynn. If you weren't here for the morning sessions, Vice President of Communications and your moderator for the webinar. Unless you're presenting, you should be muted, and only the presenters will need to activate their cameras if they wish. But first, we will need to do the required CME disclosures. The Illinois Academy of Family Physicians adheres to the conflict of interest policy of the ACCME and the AMA. It's the policy of IAFP that all individuals in a position to control the CME content disclose any relationships with ineligible companies upon nomination or invitation to participate. All 6 of our speakers in this block have indeed submitted their conflict of interest forms. So Dr. Chan, Dr. Sagdireddy, Dr. Kuchar, Dr. Howe, Dr. Omo Ibo, Dr. Gorty, and Dr. Master, along with myself, disclose no relevant financial conflict of interest with a proprietary entity distributing healthcare goods or services. So with that being said, here's about how claiming CME credit will work. A link to the post-test evaluation and credit claim will be put in the chat box. In fact, it's in here earlier, and I'll put it in a few more times. Make sure you only claim credit for the presentations that you view. You'll be able to select them, and then you'll be able to download and save your CME certificate. If you're watching this recorded online, you'll find the link to that post-test at the bottom of the description in the video. So under the video, just go click on more and you will find the link to claim your credit. Just a couple of upcoming events. We do have our foundation fundraiser. This is found on our website, IAFP.com, under events, and also with the QR code. And then all of our residents who are presenting, we encourage you to submit it as an abstract for the Family Medicine Midwest Conference this September in nearby Naperville, Illinois. Call for abstracts is open and closes June 1st. So make sure you get that done. And of course, everyone's opinion matters. Be sure to send us a review on Google. You can use the QR code, or the link will be also sent in tomorrow's follow-up email. We have a couple of guest presenters and some anonymous faculty reviewers that are named after television doctors. They're the only ones who will be able to ask questions. So how this works, each resident will have their presentation ready to go from their own screens. They'll have 15 minutes to present. There'll be a 2-minute warning if you get that far. And then if you hit 15 minutes, we'll ask you to wrap up in order to keep us all on schedule with a busy block. And then our TV doctors will be able to either unmute and ask their questions verbally or submit it in the chat box. I see our first presenter is up and ready. So with that, I'm going to stop sharing my screen. And as Dr. Chan is pulling her slides up, I'm going to introduce you all to Dr. Israela Chan from the St. Mary's Chicago Family Medicine Residency Program, presenting her completed project. And her 2 faculty reviewers will be Dr. Sarah Reese, and welcome back to Dr. Natalie Manning. Dr. Chan, I can see your slides. If you're good to go, the clock will begin when you do, and we wish you good luck.
One sec, trying to minimize Zoom. Okay, so hi, I'm Izzy, 3rd-year resident at St. Mary's Hospital in Chicago. So today I'm going to be talking about a project I did for my actual faculty development project with my residency program. So we were tasked to create like a curriculum and then do a lecture for like one of those days, basically, or for one of those sessions. I have an interest in EMR and kind of how to leverage EMR to make our lives easier, basically. So I wanted to develop a lecture where I could kind of go through MedRec and how to do it more efficiently using our EMR systems. So this is kind of the overview, kind of background, needs assessment, objectives, lesson plan for that day, and also evaluation methods. So first of all, why do we care about MedRec? So this is from a report from the WHO, I think in 2019. Basically, up to 97% of adults have at least one medication discrepancy on admission to the hospital. 62% of patients have at least one unintentional medication discrepancy during internal hospital transfer. And 25 to 80% of patients had at least one discrepancy or failure to communicate in-hospital changes at discharge. So this is actually, it seems like the majority of patients, and it's not just in the US, it's a like global worldwide issue. And then since EMRs have become like more standardized and like introduced more like into workflows, they've had both kind of like good and bad impact on how we do MedRec and medication errors. So for benefits, there have been studies, a few studies showing that medication errors have decreased like since we've included EMR in the workflows for MedRec. partly because with the technology, we're able to get records from like so many different sites. You're able to like kind of coordinate between facilities, which makes it a lot better to get all the patient's information in one place. And it also has a lot of really good tools as well, like fill history, like ILPMP, and also being able to see or bringing outside information into your EMR. So those are all great things, but there also are still some challenges with using EMR for MedRec. It's really EMR is only as good as the user, basically. So there can still be inaccurate or like incomplete data in the system. And a lot of places, including my program, didn't really have a set workflow for EMR, like in clinical care, basically. So that can also be an issue for adoption. They've been talking about interoperability for a long time, actually, for EMR, like basically communicating between EMR systems, but still, it's still pretty hard to get data between like two different systems. And there's still barriers for patients themselves and also providers to like access all the data like from our EMR and other EMRs too. So as I was kind of looking at my program in terms of our like admission workflows and MedRec workflows, so we didn't really have a standardized workflow for admission MedRec. I watched like a lot of different residents, both seniors and like interns, and everyone kind of did it differently. And a lot of residents weren't really aware of what tools were in Epic, what tools were in Athena. So that was also kind of surprising. Well, a little bit surprising. And then I also got a lot of feedback from residents on when we are doing admissions, what exactly are we doing for the MedRec on admission? Like what exactly is this prior to admission med list? I also have people asking me for help, I guess, like in Epic and in Athena pretty regularly, but there's also concerns like we don't really have practical training on EMRs in our programs, at least in our program. So basically, if there's these like misunderstandings or like not like fully understanding what exactly we're doing for the PTA meds, it leads to like incorrect MedRec on admission, which then kind of like transfers throughout the entire hospitalization, which then leads to like incorrect discharge summary med list. So there's a lot of patient safety issues that can happen like just from not doing this MedRec correctly when a patient gets admitted. And then just by having or at least for our program, like all the residents doing admissions differently, it can lead to like more errors and also it's not really efficient, basically. And there's so many tools in the EMR that we're not using that can make our MedRec faster and also more accurate too. So for my curriculum and for my didactic session, I really wanted to focus on increasing or getting everyone on the same page for like what exactly MedRec is, kind of using like a pre and post test to kind of see how they do on that. And then I also want residents to be more comfortable actually doing MedRec and also using the EMR too. So I kind of used kind of a fun scale to measure that. And I also wanted to make sure that residents had a chance to actually practice and actually do like a proper MedRec. So those were my goals like for my didactic session. In terms of the curriculum design, so for my lesson plan, so this is kind of like our 1 hour didactics during lunch. So the night before, actually, for the prep, I actually started prepping like the night before. And then I'll just kind of go through it really quick. Let's see. Yeah, I'll just go through it. So for the prep, so the night before I messaged kind of the group chat just to get people thinking about their patients and who they could do the MedRec for during the didactic session. So I recommended selecting a patient that they recently saw in clinic because their med list should be up to date, or at least they should know like what their patients are taking. But it was also crucial to make sure they had a chart in Epic, basically. Unfortunately, we use Athena in our clinic and Epic in our inpatient setting, so it makes it more difficult. So when I had the computer lab booked for the NetX session, so made sure all the computers and everything were working beforehand. And as people were kind of logging in, getting Athena up, getting Epic up, I had them complete this pretest on the side right here. So they're pretty simple, like 3 questions. And also I did use the pain scale to see how MedRec made them feel at the very beginning. Hopefully, yeah. So after everyone got settled, I kind of just went through like what exactly is MedRec. And a key thing that I wanted to emphasize is the best possible medication history. So BPMH, it's a really weird term, but it's the official one for kind of like the medication list that the patient of what the patient is currently taking at the time of admission, time of transfer, time of discharge. I also went through kind of like the organizations that kind of monitor like MedRec and also like just all the patient safety, like the importance of MedRec with patient safety. This was just through PowerPoint presentation. After that, I actually went through and took screenshots of kind of a proposed admission workflow basically, and then had that in PowerPoint. So it starts, I focus mainly on the beginning of the admission when we get kind of like the patient history and then figure out like what they're actually taking and then enter it into the EMR. I have some examples of kind of what those slides look like. So for example, in here, so I tried to kind of highlight things so it's really easy for people to go back later and kind of know like exactly what tab to press on and like what section to click on as well. Make sure to cover any PHI, so don't worry. And then just another example of like, this is how you enter medications. So I did go through workflow from Athena. So like getting the clinic medication list from the patient for that patient, and then and then figuring out like what they're actually taking. So after I kind of went through like the admission workflow, I actually had everyone that logged in do it themselves. One issue was that I can't really simulate admissions for all the patients. I wish I could, but I did find a workaround in Epic at least that we can create like a different encounter so that you can still practice MedRec and it'll update the patient's medication list, but it's not like they're actually being admitted. So I'll kind of show you guys what that looks like. Yep, so you would create an abstract encounter in the patient's chart and it would look something like this. So it's similar to the admission, I guess like screen, I guess, and also the prior to admission medications. But basically, I had them, like I said, I had them go into their patient's chart, use the clinic medication list, compare it to IOPMP, fill history, reconcile outside information, and kind of help them find those things in the EMR and use them as well to kind of get like the updated patient list. And then after that, I made sure that, or kind of help people go into Epic and then actually update everything. Let me see. So in terms of facilitators, I think I'm just the main one basically, but people are also helping other residents out, so. For the post-test and wrap up, so the post-test was just the same questions as the pre-test. And we kind of just reviewed the answers like as a group and then went over just like some brief questions, like kind of like what part of the process, like in the submission workflow was like confusing. Was there anything else that I could clarify? And then one question I asked was how your confidence was, like how has that changed like before and after doing this session? At the bottom of the form, I also did have a section where they could just write like free comments basically for feedback. So kind of the evaluation like for my session for learners and also for the process or like the session. the pre and post tests and like measuring their the changes in the score, and then also like kind of like their self-assessment and like their comfort level for doing MedRec. So for the first question, on the pre-test, so the question was like, what is this BPMH? The answer is the list of medications the patient is currently taking. So we actually started out pretty high already. So I mean, they still went up, but we started out pretty high. So so you did well on that question. And then I also asked what type of medication should be included in this BPMH. On the pretest, you can kind of see like everyone said like prescription meds, yes, for sure. But like vitamins, herbal supplements, like not, maybe. On the post test, though, you can definitely see that more people answered the other options as well, because we do want to include all of these in the PTA meds. For the third question is, when should MedRec be performed? Again, it started out pretty good already. So the answer is all of the above, because we definitely wanted to have them we definitely should do MedRec at any transition points, admission, transfer, discharge, so all of them. And then for the last question, having them rate how MedRec made them feel, like on the pain scale. So interestingly, for the pre-test, it's kind of more varied. The average was like around a 4, but you can kind of see the skew. For the post-test, you can see that the scores are definitely decreased overall, which is great. And the average score was like around a 2. So in terms of like if I achieved my goals for evaluation, I think I didn't meet the 20% exactly, I guess, for the increase in the score, but they also started off really well. So, but I think I did accomplish my goal of having people feel more comfortable doing MedRec and also using all these tools in the EMR to do it as well. And then just some of the comments like from the free response section. Let's see what else.
You have about 30 seconds left.
Okay, so future plans for me, taking this PowerPoint, making it into a tip sheet, and then also working to incorporate like more EMR, like lectures for future didactics, and also talking with pharmacy as well to see if we can do any like integrated process for MedRec. And that's it.
Wow, you came in just under. Well done, Dr. Chan. So now I will turn it over to our 2 reviewers, Dr. Reese and Dr. Manning. You can either unmute. It looks like Dr. Reese has put a question into the chat for you.
Okay.
It says, great topic, very relevant. I like that you included hands-on practice. How long ago did you give this presentation? And since then, at least anecdotally, have you noticed a decrease in issues of MedRec during hospital follow-up appointments in your clinic?
It was actually about last month. So unfortunately not too much time like in between from when I gave the presentation and like now. But I have talked to a few residents, and I think, again, just from me like looking at some discharge summaries, I feel like there's less like ambiguous, I guess, medication changes on the discharge summaries. So I feel like anecdotally, like there is some change, but I would have to probably like pull more discharge summaries to look at and also talk with faculty and the residents again and see if there's any changes.
Yeah, she says makes sense. And after seeing all your screenshots, I feel your pain for all of you. Makes me, I'll complain less about the work I do with our association management system and data entry compared to what you all are looking at on your screens. All right, let's see if Dr. Manning has any questions.
Yes, thank you. I agree with Dr. Reed that it's a really important topic, and agree also that the hands-on is wonderful to really help people learn. You had a nice logical approach to curriculum design, and I like the cute faces for the MedRec. How did you perform the needs assessment?
For me, I didn't do, I guess, like a formal survey. Our classes are pretty small, like only 12 per class. So I actually did talk to most of the seniors and also talk to the interns to kind of get their thoughts on what our admission process was like and like kind of what issues they had. And then I also went through and like, I guess, did like chart audits, I guess, to kind of see like if the PTA medication list was actually completed. Did the residents like actually review it? And then I also did audit some charts for the discharge summaries as well, to see if they were completed, well, if they're completed correctly, basically.
Good, thank you. What was the analysis in terms of, did you do a t-test, paired t-test or unpaired t-test on the pre-test, post-test, or you were looking at the simple?
Just the simple percentages, but it's something I could definitely look into.
Yeah. If you have your pre-test and post-test linked, are they linked? Or they're like a group of pre's and you've got a group of posts that you're comparing?
So it's kind of like I did it, so it's like the front and back of the paper. So yeah. So I kind of just had them grouped basically.
So
Yeah,
if you did the front and the back of the paper, you could do a paired t-test, and that would be more sensitive for change. So I recommend that you do that. And I really appreciated the narrative comments that you made too. That's
Thank you. Okay.
All right. Our thanks to Dr. Chan and to our reviewers, Dr. Reese and Dr. Manning. So now we're going to transition to our next presenter, coming to us from the Hinsdale Family Medicine Residency Program. We have two presenters together, Dr. Shravani Sagareddy and Dr. David Kuchar. And then I'm going to ask Dr. Manning to stick around for another presentation and welcome Dr. Addison Montgomery as our other faculty reviewer. Dr. Sagareddy, you can share your slides as soon as you're ready. Just a reminder, you'll have 15 minutes. The clock will begin when you all start presenting. I'll give you a 2-minute warning, and if you get to 15 minutes, I'll ask you to wrap up to keep us on schedule. All right, and we are starting to see your slides, and other than that, I wish you the best of luck.
Perfect. All right. Okay, great. Hi, everybody. Thank you for joining us. I'm calling in from Hinsdale Family Medicine Center out in Hinsdale, Illinois. And I have David Kuchar. He's my co-presenter. He's doing an away rotation right now, so he's zooming in from Florida. All right, so we looked at improving continuity of care at Hinsdale Family Medicine Center. We don't have any conflicts to disclose. All right, so what is continuity of care and why is it important? So continuity of care emphasizes quality care over time. The goal is for the patient and their physician-led care team to work towards the same goal of providing like high quality, cost-effective medical care. And this, we believe, is the hallmark of family medicine. With our short appointment times, there is benefit in knowing a patient for more than one visit and, allowing us to continue to focus on different aspects of their care appropriately. And this not only relates to a PCP, but continuity of care for patients in all aspects of care. So let's see. And so this goes towards for patients and all even their specialists, not only their PCPs. All right, so continuity of care can lead to improved patient and physician satisfaction, increased use of preventative care, and decreased hospitalizations and emergency department visits.
So a bit on what we did and how we went about it. We wanted to see if the various efforts in improving continuity of care in the residency clinic would have an impact. And notoriously, I think residency clinics tend to have somewhat lower rates of continuity compared to your typical outpatient family med provider. In a recent review that we found it's about 56%, which feels true compared to faculty usual provider care, which is quite a bit higher, up to nearly 80% in that review that we saw. So most of the family medicine residents, I think, would agree that we chose family medicine in large part because of the continuity that we're able to provide our patients. In residency in particular, there's many obstacles. There's limited clinic hours. Sometimes they shift around. There's sometimes canceled clinic sessions. There's sometimes you're on call or in the hospital, which makes having a consistent schedule somewhat challenging for both the patient and the provider. Next slide. So part of the reason we chose to focus on continuity of care was triggered by the ACGME's 2024 update to their guidelines to more emphasize the continuity as opposed to the raw numbers that they previously used to emphasize. And so the emphasis now lies more so on scheduling the clinical experiences to be more related to continuity as opposed to just raw numbers. And go ahead. Yep. We were asked to also note the fact that we're both DOs from the Chicago College of Osteopathic Medicine, and really everything we do does filter through these osteopathic tenets upon which our medical education was based. And those specifically we wrote out there. The person is made up of mind, body, and spirit, and the idea that everything is interconnected structurally, functionally, internally, the body's ability to heal itself, and treating patients in this on the basis of these principles. So our research project, I think, is consistent with these values. I think it feels relevant to those. Having continuity of care, I think we've all seen, does improve how patients experience medical care and healing.
So our objective was we sought to determine the effect of continuity clinic days and easily identify a primary care provider on measures of continuity in our family medicine residency, and to develop an idea of whether our measure of continuity meets what ACGME outlines for a family medicine resident. So to do this, we did essentially an observational study to assess the impact of establishing continuity clinic days and identifying primary care providers. So the measure of continuity of care as per ACGME is for patient-sided continuity of care. For PGY2s, they expect 30%. For PGY3s, expect 40%. And similarly for resident-sided continuity of care as well. So for the methods, there were different ways we tried to accomplish this. So there's regular operational meetings with the front desk staff, with our nurse manager, with our clinical medical director, as well as residents, to discuss just like the general idea of improving continuity for residents. Major interventions include initiating continuity clinic days for each resident, and our new Epic EMR identifies PCPs more easily. So we did transition from Athena to Epic at the end of our first year, and we're third years currently. And then implementation of the continuity clinic day started in July of 2023. And again, the Epic went live November 2023. So now you can see primary care providers easily listed. So residents are listed as patients' primary care providers. And then the patient-sided continuity was measured as a percentage, so calculated based on the number of visits that a patient saw their assigned PCP.
Yeah, so we have a bit of a breakdown of some of the numbers. We should have probably put the year. This ends in 2024. Yeah. And the keen observer would notice that this is a fairly select chunk of time, about a year's worth. I think, as most research projects are fairly ambitious, we were certainly ambitious. We quickly ran into a number of challenges. For example, getting data for visits that occurred prior to our epic transition proved to be effectively not possible. Then the more obvious thing you run into is that you also get data that where you have transitions of patients from, say, a PGY3 to a PGY1, and so you get a pretty complicated and maybe unusable set of information if you try to go beyond that in our experience. So that was one of the first challenges we had. We do have some overall kind of ideas of over that time period what those numbers looked like graphically. I think that's oftentimes helpful. Now, the one thing to note as we look through this PGY2s and then PGY3s, virtually, except for PGY3s early on with the average, virtually we were always above the threshold requested or suggested by the ACGME. And then we did see an upward trend, at least for the PGY2s and 3s, which we'll have some discussion about shortly. So some takeaways. Getting continuity numbers up, it's a team effort. There's front desk staff, there's individual residents, there's all the support staff involved, there's the scheduling aspect of things. Many variables, I think much more so than you would see in a community or faculty practice. For us, our patient-sided continuity, we averaged about that 48%, which I think was pretty comparable to some of the reviews that we looked at as far as targets and baselines. Now, establishing a causal relationship or, supposing the real challenge for us was setting a baseline. Like, what's our starting point? Where are we going? And then if we were to state a null hypothesis, it would be based on what baseline, where do you put the starting point? How do you account for the various factors? And then the other aspect is you have multiple efforts going on. Some of them were pushed forth through the efforts of this project. Some of them were already going on because of the ACGME shifts. And so you had quite the stew of factors and influences and variables playing into what might be imputed to be a causal or just correlated relationship. There is likely, I think, a ceiling for continuity, especially in the residency setting, just due to the factors that we mentioned. But I think seeing an upward trend was reassuring for us that the efforts as a whole were pushing things in the right direction.
Yeah, and like we discussed, like there are confounding variables. So as residents progress in training, they have more availability and increased patient exposure. So as third years, we do see more patients in a clinic half day than, say, second years would or first years do. And you get to know your patient panel more with that increased availability. So then your patients tend to know who you are and come back to see you. And then residents also have access to their appointment time. So you can so it's easier to facilitate when patients should return to clinic. So let's say you see a patient sitting in clinic and you're like, I want you to come back in 4 weeks. Then you can kind of look at your schedule and be like, hey, I'm in clinic at this, I have these openings. Why don't you let the front desk know you want to schedule it then? And then also we got business cards allowing patients to have their PCP's name and information because, we are a residency of 27 residents. And so with various providers and insurance, having our attendings providers' names on it, it's hard for the patient to know. So business cards we find are actually really helpful. So that was another component of, a variable that kind of played into part, and seasonal constraints. So summer you see more pediatric patients versus maybe you have more sick visits, and then end of the year, like end of a calendar year comes with its own challenges. So things like that too to think about
Yeah.
of like patient quantity. And
Yeah.
so, yeah,
Yeah.
go ahead.
To add on to that, I mean, the data unfortunately wasn't granular enough to differentiate between an acute visit that you just see the acute provider versus a last minute sports physical, like Shawnee alluded to. And so some more granularity in the data would be certainly interesting to work with. So as far as future projects, implementing some more specific initiatives that would yield maybe something a little bit more measurable, something we can have a structured, potentially scalable, something we can share with other programs. And then what we looked at was, as we alluded to earlier, was a patient-sided continuity. So basically, patient had a visit, was it with their PCP? And so looking at the flip side of resident-sided continuity, that data wasn't available to us at the time, but looking at it kind of from the mirror image, which the numbers should probably be similar, but there's sometimes key differences as to whether residents are seeing their own patient panel. And then there's some pilot programs out there for team-based coverage. We are sort of trying that in our program separately, but that can potentially be part of the solution for promoting continuity.
And then finally, we just wanted to say thank you to our attendings, Dr. Backold. She is our clinic medical director, and so she really helped us implement a lot of our continuity initiatives. Dr. Kien, he is our research director, so his patience and guidance throughout this journey is much appreciated. And Mary Ann Harrelson, she is our billing person, and she graciously collected all the raw data for us to be able to analyze it and push it forward for our project. Some references, and that's it for us.
Well, thank you to you both. And we have a couple minutes for questions from our two reviewers. Dr. Montgomery or Dr. Manning, you can unmute or throw a question in the chat for either of our presenters.
Thank you. I think continuity of care, the ACGME is struggling with that, but it's probably the key thing that makes family medicine so wonderful. I was wondering about, was there a personal impact of putting this study together or the results of the study for each of you?
Yeah, and I think David and I are good examples of this. We do tend to have a lot of continuity, and we can see that in our day-to-day schedule. So my continuity clinic days as third years, I get 2 of them. So I get a Tuesday morning and a Wednesday afternoon, or Tuesday afternoon and Wednesday morning. And I think my patients have really taken to that because they know, oh, Dr. Sagarati is going to be in clinic on these days. I can make sure to be in like at that time. So I find that I do get to see a lot of my own patients with the addition of clinic continuity days. David, if you wanted to speak on that.
Yeah, I think for me, it highlighted the complexity and kind of many moving parts that come into play with running a residency clinic and trying to do something like improve continuity. I mean, even efforts like setting specific days for continuity had some positives, certainly has some drawbacks, you know, during the orders where I don't have evening clinics, for instance, there's some patients that aren't able to see me. And so you get things like this. And then I do think even the awareness of trying to promote continuity, I think is helpful. I mean, there's been a few instances where, you know, I'll have a colleague's patient on my schedule for whatever reason. I'll be like, hey, you're seeing my patient. This could be switched or rearranged, or kind of with the business cards or just being aware of it, I think helps you to promote that for your patients and kind of take ownership of like, hey, I'm your PCP and I'd love to see you. And however long I need to see you.
Yeah, and I think even moving to Epic, we were on Athena and we didn't have any access to seeing like what open slots we had or like when, you know, what was available in the future. So even having that capability now, like I can say it's easier because I know like, hey, I'm in clinic this day, let's squeeze you in at this time to be able to get you in with me versus a different provider. So just being
Sounds good.
prepared.
And
Yeah.
I appreciated your thoughtful discussion about it too. And I would go ahead and add that null hypothesis in at the beginning of your slide deck if you choose to submit it to Family Medicine Midwest, which I hope you will. How do you count for the PG1s? They didn't have that positive.
Yeah, so I personally think, yes, I think having a little bit more statistical analysis will give us a sense of like, are these numbers even, you know, is the trend really there? But the PGY1s, I mean, I think it's probably a result of the schedule. You know, I think, Shravani, is it 1 day a week they have a clinic?
Yeah, so as chief, I do a lot of the scheduling, and for us here, we do a lot of inpatient our first year. And so at most our PGY1s are in clinic like once a week, and if on an elective service, they're a little bit more like maybe 2 to 3 times a week, and they start with an hour appointment per like half day for the first 6 months. So their time is a lot more limited. And so that would be an interesting like measure to look at is like how do we improve PGY1 continuity given the constraints of our scheduling?
Their numbers, as far as patient visits, are just so much lower that I think
Yeah.
that limits just the leeway they have partially. So that's a trickier one, especially for the first 6 months. Time of year is a big one, actually, it seems like.
Yeah.
Yeah, it did seem like it got worse the second year you measured it in PG1s.
Yeah.
Thank you.
Yeah, thank you.
And I'll add my thanks as well to Dr. Sagaretti and Dr. Kuchar. To keep us on schedule, I'm going to ask for our next presenter to tee up her presentation, and we'll welcome Dr. Jenny Howe also from the UChicago AdventHealth Hinsdale Family Medicine Residency Program. And once again, I'll need Doctors Montgomery and Manning to stick around and serve as our faculty reviewers. Dr. Howe, you have your completed project, and you can go ahead and share your screen. We'll make sure we can see you and hear you.
Hi, good afternoon. Can you guys
Hi.
hear me?
I can see you, can hear you. You can start your
awesome.
slideshow, and the clock will begin when you do. We wish you good luck.
Okay, perfect. Thank you. Hi, good afternoon, everybody. So thank you for the introduction. My name is Dr. Howe, and today I'll be going over my project, addressing the needs of low-income families through WIC, which is known as the Women, Infants, and Children Program, a survey of patients at Hinsdale Family Medicine Clinic. So I have no disclosures for this presentation. So a little background information about WIC. What is WIC? So WIC is a food assistance program for low-income women that includes pregnant, breastfeeding, and postpartum women, infants, and children up to the age of 5 years of age. So in order to qualify for WIC, families have to meet a certain income level. So they specifically, families have to fall at or below 185% of the U.S. poverty income guideline. So for example, for a family of 4, they have to have a maximum income of $55,500 or less per year in order to qualify. In addition to that, participants must also be a resident of the state that they're applying for assistance, and they also have to meet a nutrition risk that includes a medically based risk, which is essentially documentation of having anemia, being underweight, having maternal weight loss during pregnancy, history of pregnancy complications or poor pregnancy outcomes, or diet-based risk, which is having a poor diet or food insecurity. So this is an example of the Illinois WIC medical form that physicians that we use in the clinic. So this allows physicians to essentially document proof that a patient is anemic or they were born with a low birth weight, or any evidence of like poor pregnancy outcomes, for example. Just any evidence of like a medically based risk that would qualify the patient for WIC.
And essentially you can fill this out, give patients the form back so that they can bring the form to the WIC office. So what does WIC offer? WIC offers a variety of different benefits. One of them includes supplemental foods, where participants are given an EBT card where they can bring the card to grocery stores and use that card to buy nutritious foods like fruits and vegetables, milk, juice, eggs, etc. Participants are also given infant formula. WIC also offers nutrition education, like free health and nutrition education classes. And then WIC also provides access and education regarding other healthcare and other social services like prenatal programs, vaccine and child clinics, and drug and alcohol treatment programs as well. In addition, something I was surprised to learn about was that WIC also offers breastfeeding and lactation support to breastfeeding moms with the help of certified lactation specialists. So how do our patients apply to WIC? So our patients can go to the Illinois Department of Human Services where they can select the county that they live in. And then it will pull up a variety of different locations that are, and then they can pick a WIC office that's closest to where they live. So for example, at the Hinsdale Family Medicine Clinic, the closest WIC office to our clinic is the one in Westmont, also known as the DuPage County Health Department in Westmont. So we refer a lot of our patients that live within that county there. And you essentially tell your patients to call the office, set up an appointment to see if they're eligible. And in order to do that, they have to bring various forms of documentation, including like proof of income, proof of identity, proof of residency, for example. So the objective of this project was to spread awareness about the WIC program at Hinsdale Family Medicine Clinic and to educate patients and family members about the WIC program and the benefits that the program provides. And by educating the patients and family members about the WIC program, really encourage patients and family members to apply to the program so that they can utilize the resources the program provides and to help them during difficult times of need. And I think this project really gave us a good understanding of how underserved our patient population is at Hinsdale Family Medicine Clinic, and also allowed us to understand what the needs are of our patient population. So throughout this project, a social determinants of health questionnaire was implemented and given to patients to fill out when they checked into the residency clinic. So this is on the left-hand side, the questionnaire that I used. This questionnaire is already in place and implemented prior to the start of this project by our case manager, Katie Penny. But for the purpose of this project, there was a question regarding WIC that was incorporated into the survey at the end of the survey to help screen for patients who could potentially meet criteria for WIC. And then 2 questions that were included to help screen patients were, first one being, are you or a family member pregnant, breastfeeding, or caring for an infant or child under age 5 years old at home? And if so, would you be interested in learning more about the Illinois WIC program, how to see they're eligible, and how to apply? So patients had the opportunity to check yes, no, or they're already using WIC services. So surveys were collected between February to September of 2024, so a total of 7 months of data collection. And the groups were divided into 2 focus groups for data. The first focus group was patients that did meet criteria for WIC, meaning that there was a woman that was pregnant, breastfeeding, or postpartum, or there was an infant or child age 5 years of age or younger at home. And then they also expressed interest in learning more about the program. And the second group was determining the patients that had already qualified for the WIC program and were already using program benefits. So this data that was collected was recorded and organized into an Excel sheet. And patients who did express interest in learning more about the program, they were called over the phone, they were educated more about the program, how to apply, and they were also mailed WIC pamphlets as well to their house. And throughout the 7 months, these patients were called several times for updates to see if they were able to apply to the WIC program, qualify for the program, and utilize their benefits. So this is an example of the Excel sheet that I used to help categorize my data. So I categorized patients into interested, not interested, or already qualified for WIC. And if patients were interested, were they contacted and what were the outcome of the contact? And the main focus and the hope was that patients were educated about the WIC program enough to the point where they could apply, hopefully qualify, and end up using the WIC benefits. So at the end of the project, the total number of surveys I've collected was determined, and the total number of patients that already qualify for WIC and are already using program benefits was determined. The number of patients that met WIC criteria and expressed interest in learning more about the WIC program and applying to the program was determined, and these patients who did express interest were further subdivided into two groups as data. The first focus group was the percentage that applied and qualified for WIC, and the second was the percentage that was lost to follow-up or no longer expressed interest in the WIC program. And at the end, the number of patients that were educated about the program has successfully applied, qualified, and were able to utilize the WIC benefits was determined. So, and again, a total of 463 total surveys were collected between February to September 2024. 78 patients met criteria for the WIC program, and out of these patients, 44 patients reported that they were already receiving WIC benefits, which means that 56% of patients that were screened who met criteria for WIC had already qualified and were already using WIC benefits, which I think is a substantial amount. And then the other 34 patients out of 78 patients reported being interested in learning more about WIC program and how to apply for it. So in this specific subgroup of patients that were interested in learning more about WIC, these patients were again educated and closely followed up on. Out of these 34 patients, 9 patients did end up applying and qualifying for the WIC program and successfully received WIC benefits. So overall, towards the end of the project, over 25%, which specifically 26.5% of 34 patients who reported being interested in the WIC program did end up successfully applying, qualifying, and utilizing the WIC benefits. The other 25 patients were either lost to follow-up or were no longer interested in the program. So language was a barrier to patients applying to WIC. Some top primary languages that patients spoke outside of English at Hinsdale Family Medicine Clinic were Spanish, Urdu, and Chinese. So you can see on the right-handed side that the amount of patients that spoke English were more likely to apply and qualify for the WIC benefits compared to other patients that spoke another primary language. So in conclusion, the social determinants of health questionnaire was a useful screening tool to screen for patients who met criteria for WIC. And by screening for patients who met criteria for WIC and expressed interest in learning more about the program, we were able to spread awareness and educate these patients more about WIC. Again, over 25% of those who did express interest in WIC were successfully able to apply, qualify, and utilize benefits. And 56% of the patients who did meet criteria for WIC already qualified and were already using WIC benefits. And this is important because inflation and prices are going up and families are struggling to make ends meet. So as physicians, educating patients and our families about community resources is really important because I think that if we don't have access to our basic needs, that puts more stress on our body, and that also has a really negative effect on our health. But overall, this project provided us with an understanding of how underserved our patient population is and the needs of our patient population at Hinsdale Family Medicine Clinic. The language, again, was a barrier to patients applying to WIC. Some potential future recommendations to help increase rates of WIC applications amongst patients who speak another primary language may include mailing WIC pamphlets in a different language or helping to find WIC locations with staff that speak the language. Overall, the implementation of a social determinants of health questionnaire across clinics in the U.S. may help spread awareness about the WIC program and increase WIC applications amongst patient populations that need these services, especially in times of need. So I definitely want to give a great thanks to Katie Penny. She was our previous case manager who no longer works in the clinic, but she found an opportunity elsewhere. Dr. Kian, he's our attending physician, and the rest of the Hinsdale Family Medicine Clinic front desk staff for their help and contribution in this project. This is my references in the end.
That's a great picture to end on. Thank you so much, Dr. Howe.
Thank you.
All right, at this time, I will ask if Drs. Manning and Drs. Montgomery would like to ask any questions.
Thank you, Dr. Howe. I think this is a really good project, and I think highlighting the need in our community and encouraging to see that, you know, more than half were already connected to services. If you were going to design kind of the next steps for this project, so getting that other half of patients and that I guess 75% that was kind of lost to follow-up, what do you think? I mean, you mentioned language, any other things, any other barriers or kind of ways to directly connect patients to services that, you know, came up for you as you were reviewing your kind of reaching out to families and reviewing your data?
Yeah, so I definitely think that for next time there, so in terms of like language, I think that you know, having close follow-up and calling them again, or essentially like leaving a message saying that, hey, like there's on the website, you can give them like the website, and on the bottom of the page there's the option on the WIC website where they can select different languages, not only in English, but you know, Chinese, Urdu, etc. I think that would be, you know, a good way to say that, hey, I know that we lost follow-up, but leaving a message saying there's, you know, still an opportunity for you to learn more about the WIC program. You can go on this website, the WIC website, and on the bottom of the page there is the option where you can check off a different language to help translate for you, so you can learn more about the program. And the other option is so in terms of the other area was transportation. So I think there's various resources in our community that do offer free transportation, like Interfaith Community, which is essentially a church that offers free rides to for patients to go through appointments, such as doctor's appointments, for example. So I think perhaps following up with patients, and if they're not able to be followed up on, leaving a message and saying, hey, this is a great opportunity through the Interfaith Community Partners regarding transportation options, so that you can make your appointment and hopefully apply and qualify for WIC. So we do have a new case manager. So I think at subsequent visits, when those patients who are lost to follow-up do come to their appointments, perhaps setting them up with our case manager and having the case manager speak with them one-on-one, assess what their needs are in terms of what the insecurity they have, and having our case manager give them their contact information and having the patients contact him if ever needed. So I think those would be some good ways to address those barriers.
Yeah, it takes multiple people and probably across multiple visits too, right?
Definitely.
Thank you.
Most patients are very perceptive and accepting of help. So I think that's very reassuring to hear and to see.
This Dr. Manning, I agree with Dr. Montgomery. Such an important study to continue to examine our social determinants of health. Who was it that staffed the project? Who called the patients in follow-up, and who administered the original questionnaires? And did they have a training program?
It was the original case manager, Katie Penny. She is unfortunately no longer working in our clinic. She found an opportunity elsewhere. So it was originally her who implemented the original questionnaire a few months after I started my project. But I did use the questionnaire, and by implementing those questions specific to WIC. So that was already in place. So I was very fortunate to have her be my mentor. So it was a combination of me and her who did call patients and then follow up with these patients throughout the 7 months that we did this project.
Yeah, I want to applaud you on the numbers that you got, 463, and were able to do the follow-up. Who was it who got the surveys? Was it only women, or was it also men who were bringing in children? How was that determined?
Yeah, I will have to say I would not have been able to do this project without Katie Penny. So I'm very thankful for her and her contribution to this project. But anyone who walked into the clinic will get the surveys. It was a little bit hard to kind of distinguish who had children, who didn't have children, if a woman was pregnant, not, if they were breastfeeding, or if they were postpartum. So essentially, just to make things easier, everybody got the surveys. But what I found was that even if the men did get surveys, some of these patients did have children, and they would check yes for that box because they did either have an infant at home or they did have a kid that was 5 years of age or younger at home. So those various patients. There was really no specific group or specific age of patients that we targeted, but if they were children, then of course the mother or the dad did get the surveys as well. So I think oftentimes we do get a lot of like kids who come into the clinic, so the parents would be the ones filling that out. But if it wasn't a well-child visit, for example, if the mom or the dad came in for their visit, they'll be the ones checking off, confirming that they do have like an infant kid or a 5-year-old kid that's 5 years or less at home as well.
So were all adult patients sampled? The 463 was all adult patients during that time?
Yes. So they were all adult patients who did come in to fill out the survey, but in terms of appointments and in terms of people, when patients were scheduled, there were like child visits where there were like kids that came in who were 5 years or less. So, kids that came in like they were coming in for like their 5-year-old well child check, or they came in for their newborn well child checks, then these parents were the ones that were given the surveys. Not necessarily like the parents were the patients, but if the patient was the child of that parent, then the parents would be the ones to fill that out. Other than that, there were also like adult patients as well. So it's a little bit hard to, distinguish from the front desk to know if that adult patient does have a kid or not at home. So all patients, whether they were adults or whether they were coming in for a well child check, were given the questionnaire.
So was it only during certain periods of time, or 463 patients is the total number of patients seen in your office during that time?
It was the total number of time from 7 months. There were some instances where perhaps the front desk did, forget to, hand out the survey. Or there weren't like enough surveys printed out and handed. So there were some lacks or less data on those dates that surveys weren't handed out, but the total was 463 surveys that were collected over a period of 7 months.
Thank you, and I look forward to seeing more maybe in Family Medicine Midwest. Thank you.
Thank you. Thank you so much.
Thanks, Dr. Howe, and thanks for Dr. Manning for the ongoing reminder about Family Medicine Midwest abstracts, which are being accepted until June 1st. At this time, I'd like to welcome our next presenter in this block from Jackson Park Family Medicine Residency Program, Dr. Omovodo Omo-Ibo, and I believe she's already on board. If you want to go ahead and start sharing your screen, we'll make sure we can see and hear you.
Good afternoon, everyone.
There you are. Okay, just so you know, once we can see your slides, you'll be good to go, and the clock will begin when you do. You'll have 15 minutes. If you get to 13 minutes, I'll give you a quick 2-minute warning, and at 15 minutes, I'll ask you to conclude so we stay on schedule. Thanks so much, and good luck to you.
Yeah, thank you very much. Okay, sure.
Oh, and just as a reminder, your reviewers for this presentation will be Dr. Sarah Reese and Dr. Abby Lockhart has rejoined us. Our thanks to Dr. Manning for all her help in this block.
Okay, thank you very much. So everyone can see my screen?
Yes, we can.
Okay, thank you very much. My name is Dr. Omobaldo Omoebo. I'm a PGY3 resident from Mount Sinai Jackson Park Family Medicine Program. And today I'll be presenting on my topic, which is approach to diet habits of patients with chronic disease living around a community hospital in Chicago and the barriers they face in achieving healthy eating habits. So introduction, patients residing in urban areas next to community hospitals show high rates of chronic disease, including diabetes, hypertension, cardiovascular disease, obesity. Dietary habits are vital for managing chronic condition, but patients encounter numerous obstacles when trying to sustain healthy eating patterns. The research examined patient dietary patterns with chronic illnesses and identifies obstacles to eating habits. So this research focused on diet barriers, so the barriers patients face in eating healthy food. And my research was inspired due to the environment where my hospital resides, the community hospital in a urban area. And during the inpatient admission, I noticed majority of the patients who were supposed to be on a restricted diet, like patient that was admitted for diabetes, uncontrolled diabetes, they're supposed to be on a diabetic diet. And when we put the order for diabetic diets, they keep requesting other diets that are not recommended for them. Like a patient with diabetes requesting, oh, can I have pop? Can I have more juice? So that's why I decided to do this research. So the purpose of this study is to explore dietary habits among patients with chronic diseases and identify barriers to healthy eating. This is ideally what we want people to eat, more vegetable foods, but this is what people mainly eat in the community where I work, where I serve. So definition of healthy diet. A healthy diet is a way of eating that supports optimal health and well-being by providing adequate nutrients and promotes disease prevention. It focuses on consuming nutrient-dense food from all major food groups in the right proportion, so it has to be a right proportion, while limiting processed food, added sugar, and unhealthy fats. So what are the importance of healthy diet? Number one importance is that it boosts energy and mood. So nutritious food like fruit, vegetable, or grain provide steady energy. It helps to regulate the body mood by keeping blood sugar stable and supporting brain chemistry. It also helps to prevent chronic disease. A healthy diet can help prevent or manage diabetes, hypertension, heart disease, obesity, certain cancer. It also supports strong immune system, like eating a food that is nutritious in vitamin A, C, D, zinc. Also, it improves the quality of life. So healthy eating reduces the risk of premature death and helps to stay active, independent, and mentally sharp as you age. It also supports mental health. So increased evidence linking diets to conditions like depression, anxiety, omega-3, fibers, and nutrient-rich food may protect mental well-being. Also, weight management. Eating healthy helps maintain a healthy weight without extreme dieting, reducing the risk of obesity-related diseases. Examples of healthy diets would be Mediterranean diets, and we know the components of Mediterranean diets. So whole food, health food. Examples of the food that are seen in Mediterranean diet are olive oil, nuts, seed, fruits, vegetable, whole grain, fish, limited red meat. So the benefit of it is to reduce heart disease, stroke, and prevent improve brain health. So these are examples of Mediterranean diets. These are just the pictures. Another diet is DASH diet. So this is dietary approach to stop hypertension, which is very good for patients with hypertension. So they lower blood pressure. So these are diets that are very rich with low fat dairy, whole grains, fruits and vegetables, lean meats, poultry, fish, limited salt, sweets, and red meats. So It is great for the management of hypertension and cholesterol. So these are just examples, a picture representative of DASH diet. Also, another important diet was myplate.org. So this is a breakdown of my plates. This is a picture of my plates. This was done by the government. It's just a breakdown of each individual's plate that contains healthy food. So the breakdown of my plates for each individual, fruits, so each meal, 20% of the plates will be fruits, 30% will be vegetable, 30% will be grain, 20% will be protein, and others can be dietary. So this is just a video representation of my plates. 30% vegetable, 20% fruits, 30% grain, and 20% protein, and dietary by the sides. So this is also another way to eat healthy. So our project, now focus on our project. So in this project, we evaluated the eating habits of patients with at least one chronic disease who lives around the community hospital in Chicago. A structured questionnaire was used to assess dietary habits, assess for food knowledge of nutritional counseling, understanding of a healthy diet, cost-related barrier to healthy eating. We also assess time restraint for meal preparation, availability of healthy food, primary dietary choices, impact of diet on health, and belief regarding the effectiveness of nutritional classes and meal planning in improving diet habits. A total of 50 participants aged 45 to 75 were included in this cross-sectional analysis. And the results of this research, so based on the survey reported, 70% of the population of the patients during this research reported that they reported eating unhealthy food like snack, such as canned food, fast food, chips, soft drink. 43% never had nutritional counseling. 20% of the research study occasionally had nutritional counseling, and 32% had regular nutritional counseling. Also, 68% stated cost of healthy food was a major barrier for them. 70% stated that 70% had limited access to healthy food due to costs. 61% does not understand how their diet affects their health. And 55% stated the lack of time for daily meal preparation contributes to their unhealthy eating habits. So 55% stated that due to lack of time to prepare food, it's related to their unhealthy eating habits. 55% stated meal planning support will improve their healthy diet habits. 70% stated nutritional classes will improve their healthy diet habits. There was some limitation in obtaining our data. Some individuals did not answer some of the questions in the survey. So conclusion, after the research, we concluded that people with chronic disease in Chicago, especially those living near community hospital, encounter several obstacles to maintaining healthy eating habits. These challenges include a lack of proper healthy diet edification, lack of time for meal preparation, economic hardship, and limited access to nutritious food due to cost. Despite this limitation, a substantial body of evidence support that counseling by a dietitian is effective in improving diet quality. Good dietary habits can facilitate weight gain, improve quality of life, and positively impact blood pressure, diabetes, and lipid level. So from the conclusion, we discovered that patients living in this population, a dietitian referral should be implemented for this patient population. Physicians should also take an active role in educating patients about healthy eating habits. Even after giving referral, just a few minutes of education will go a long way for these patients during each individual patient's or physician encounter. Patients should be encouraged to engage in healthy meal planning and preparation in advance. Based on this research, we discovered that preparing meal ahead of time increased the quality of healthy food options at home and reduce the reliance on fast food. So based on this research, majority of the population believe that because they lack the time to prepare food, so they tend to rely on fast food. So when we gave them the questionnaire, if meal preparation will help, and a huge amount, 55% said meal preparation will help them in planning ahead of time, planning healthy food ahead of time. And also, we discovered there was a gap in knowledge in terms of healthy eating habits. And we also recommend physicians to provide referrals to those patients to provide dietitian referral and also educate them, a brief education about eating habits, and also educate them about proper healthy meal planning. So this is a visual diagram of meal planning. So we could educate the patient that they can make a meal planning for 3 days, 5 days, and 1 week and store it in the fridge. So when they're hungry, they can just pick up a bowl of food that has everything according to my plates, which is a very easy way to explain a good diet for a patient. Each percentage goes to each food, like vegetable have 30%. So making a meal planning ahead of time will prevent them from eating fast food, will decrease their reliance on fast food. An acknowledgement, Dr. Nazneen, Jackson Park Hospital, where I did the research, and myself. These are my references. Thank you very much. Any question?
But of course, thank you, Dr. Omoibo, for your presentation. And at this time, Dr. Reese and Dr. Lockhart, either one of you can pose some questions. And it looks like Dr. Reese has put one in the chat for me. She says, first, it's an important topic. 1, was there anything about your data that surprised you? And 2, well, we'll start with just 1. Anything about your data that surprised you?
One thing that surprised me was the knowledge gap about healthy eating. Majority of the patients said they don't know about it. And when I questioned them individually, I discovered that they've been told about it, but because they don't have deep understanding, probably they told them, oh, eat healthy. They never went down, oh, these are the food you should eat, vegetables, whole grain. So they don't have good understanding on what to eat. All they know is just healthy food. But what is the healthy food, they do not know. And I think probably it's because majority of the patients in this community, they are like, education-wise, it's quite low. But I feel just a brief explanation will go a long way. That's why I encourage every physician to just do like a 2-minute explanation, not just eat healthy. Like they say, oh, eat a diabetes diet, low sodium diet. But what is low sodium diet? Just explain better for them. Yeah.
And you kind of touched on a little bit of Dr. Reese's second question. She's asking if you have personally changed anything in the way you practice based on the results of your study.
Yes, I have. So since I did this research, whenever I see a patient that has any chronic condition that requires dietary modification, one thing I do, I use my plates to explain to them briefly, because it's a video presentation and I just go on my phone and Google my plates. When they see the video distribution, oh, this is the amount of vegetable you should eat, carrots, cabbage, this is the amount of fruit you should drink, orange, I just name it, this is the amount. And I watch them and I also tell them to prep their food, because majority of them are busy with kids. So I can just tell them, you can do like a 3-meal prep, like a 3 days prep of meal, and just store it in the fridge. As you get used to it, you can expand and do 5 days, then 1 week. So that helps them to manage their time, and it also decrease their reliance on fast food. So I've been doing that. I've been telling patients meal prep is good.
Excellent. I'll see if Dr. Lockhart has any questions she'd like to ask.
Yes. My question, well, the first question I'd like to ask is on the session, the part where you said 70% reported eating unhealthy foods, was this just overall or was there frequency? Because I would assume everyone eats unhealthy foods sometimes, but were you assessing like how frequently this was?
No, I was just assessing overall.
Okay.
So people that said they were eating unhealthy food, canned food, fast food.
Okay. And then my second question is on the structured questionnaire. Was this a questionnaire that you developed yourself, or did you find something out there to help you develop this?
I developed it myself.
Okay.
Okay, it sounds like our reviewers have had their questions answered. So I'd like to thank Dr. Omoibo for her presentation. You can take your screen down. Our next presenter is up on deck. I'll need Dr. Lockhart and Dr. Addison Montgomery to serve as my volunteer reviewers. And at this time, I'm going to welcome Dr. Bhavana Gorty from the Hinsdale Family Medicine Residency Program. She's got a completed project to share with us. Dr. Gorty, let's see if we can see you and hear you. All right, got a visual of your slides, and let's see if we can hear you.
Oh, hi. Okay. Can you hear me?
There
now?
you are. There you are.
Okay.
Hi. Welcome.
Hi.
Okay. Just a reminder, you'll have 15 minutes. I'll give you a 2-minute warning in the chat. If you get to 15 minutes, I'll ask you to wrap up to keep us on schedule. Thanks so much. Good luck. And the clock will begin when you do.
Thank you everybody for this opportunity to present my research. I appreciate it and good afternoon. My study is on the benefits and risks associated with using Precedex on patients who are going through alcohol withdrawal, and more importantly, how that it affects the length of stay for patients that require an ICU admission for use of Precedex versus using benzodiazepines on their own to be able to treat withdrawal. So for disclosures, I have no conflicts of interest. Dexmedetomidine or Precedex is an alpha-2 adrenergic agonist that's been used for sedation in severely agitated patients and intubated patients. And recently it's gained a lot of traction, particularly in the ICU where I work, for patients with severe alcohol withdrawal symptoms and agitation related to alcohol withdrawal symptoms. And so we have quite a few ICU admits for severe alcohol withdrawal symptoms who have been using Precedex to be able to treat those symptoms. However, evidence supporting the use of Precedex in this patient population is limited and has some conflicting results. There aren't that many studies that have been really done on this, but kind of 2 of them that I'll go through for a review of literature include one article in 2016 that showed a study of 79 patients that were admitted to the ICU for withdrawal that showed that Precedex led to statistically insignificant increase in length of overall hospital stay. However, there was a large increase in the usage of other sedating medications like benzos as well that could have impacted the results for this study. Another one that was in the Annals of Intensive Care in 2017 was a larger study of 438 patients that were admitted to the ICU for alcohol withdrawal, and they adjusted for age, gender, BMI, severity, And after doing all those things, did show that the group that received both Precedex and benzos had a longer ICU stay than the ones that did not and only had benzo treatment. So you can see that even between these two articles that there is a difference where one is saying that there's a statistically insignificant increase in length of stay and the other one is saying that there's quite a large difference in length of stay. So like, you know, there's conflicting results that kind of exist in data right now. So our purpose of with this study was to compare the use of Precedex plus benzos versus benzos alone, with the intention of looking at people who were admitted to the ICU and the impact that each of these treatments had on the length of ICU stay and the overall length of hospital stay in patients that are suffering from alcohol withdrawal syndrome. Our inclusion criteria include adults, so any person from the age of 18 to 80. We did AdventHealth Hinsdale Hospital and LaGrange Hospital. I actually did a presentation on this research last year with those two hospitals, and this year I expanded to another hospital to increase my N number for my data collection by including AdventHealth Bolingbrook Hospital, which is why that is particularly highlighted. The inclusion criteria also accounts for all patients needing ICU admission sometime during their hospitalization, a diagnosis of alcohol withdrawal, documented CWA score, so we can compare the severity of the alcohol withdrawal symptoms, and that they needed to be started on Precedex and or benzos within 12 hours of ICU admission. So to keep that intact or like to keep that the same within all of the population that we were taking a look at. Exclusion criteria included anybody that received Precedex for any other reason than alcohol withdrawal or any development or admissions to the ICU that included significant other medical problems that would extend the ICU admission with other symptoms that are not attributed to alcohol use or withdrawal. So we got a chart review from our medical records for you know, a bunch of patients and recorded their the age, the overall length of stay in the hospital, benzodiazepine use or not, a Precedex use or not, and then the length of ICU admission. And then performed a statistical analysis to see whether there was a significant difference in both in overall hospital stay and length of ICU between if Precedex was used or if only benzodiazepine was used in the treatment groups. So these are the general graphical representation of these results. So on the x-axis on both graphs 1 and 2, the x-axis is the number or the length of stay. For on the left, this is just depicting overall length of hospital stay. So on the left, it's Precedex plus benzodiazepines, and on the right is just benzos. The y-axis on both of these graphs represent the percentage of patients with alcohol withdrawal symptoms and their in corresponding to their overall length, hospital length of stay. You can see that both of these have like a similar regression model that I'll talk about in a second. But if you just take a look at the x-axis, you can see that there is a difference between just the scale for length of stay with the Precedex plus benzodiazepine groups versus on graph 2, the scale for length of stay on the x-axis for just benzodiazepine use. And then if you take a look at the percentages on the y-axis on both graphs, graph 1, you can see that the scale is anywhere from like 0 to 15% in terms of, you know, the number of patients that had that overall length of stay, and the percentages go from 0 to 20 and 25 essentially percent on graph 2 for the overall length of stay. So this is just a graphical comparison between the Precedex group and then the benzodiazepine group, only looking at overall hospital length of stay. My next slide will show for ICU length of stay as well. So as seen in the previous slide, the distribution of data actually does a binomial, like a Poisson or a negative binomial distribution rather than a normal distribution. So I used, with the help of my statistical analysis team, an unadjusted negative binomial regression model to be able to statistically analyze this data as opposed to like a normal t-test. And essentially what this showed was the incident rate ratio of overall length of stay for people that used the that treatment group that was on Precedex was 1.45 with a very significant p-value. And then ICU length of stay was 1.83 with also a very significant p-value. Essentially, what the data in the previous slide shows is that for overall length of stay in the hospital, patients that were prescribed Precedex had estimated length of stay that were 1.45 times longer than the patients who were not prescribed Precedex. And on overall length of stay, patients who were prescribed Precedex had estimated lengths of stay that were 1.83 times longer than patients who were not prescribed Precedex. So it's quite a significant difference as demonstrated by the p-value that shows that for both overall length of stay and overall length of ICU stay was longer in patients that had Precedex versus just benzodiazepine treatment. In summary, the Precedex use for treatment for alcohol withdrawal symptoms resulted in a statistically significant increase in the length, as I said before, of both overall hospital stay and ICU stay. ICU stays were 83% longer, hospital stays were 45% longer. And this would indicate that Precedex use for alcohol withdrawal may not result in better healthcare outcomes when compared to just benzodiazepine use alone. This study comes with some limitations for sure. The N number for this study was around 204, which makes it not a small, super small study size, but it's also not very large. And so, in a relatively small study size and possible confounding population variables, because all of these sites are within the suburbs of Chicago with close geographical proximity, there might be some confounding variables that are not accounted for within this data. So I would encourage for future studies that a greater study size and even different patient populations that should be evaluated for the effectiveness and appropriateness of Precedex versus just benzodiazepine treatment for those patients that are going through alcohol withdrawal. As a DO, there are some osteopathic conclusions that I've also made based on the principles and practices that we learn with our degree, which include the four tenets as listed here, which is the person is made up of mind, body, and spirit. Structure and function are reciprocally interrelated. The body has the ability to heal itself, and we treat patients based on these principles. I feel like my research project furthers these four tenets by increasing the understanding of how medications can hinder the connection between mind and body, and that when we use the appropriate treatments, we can actually help the body work through an uncomfortable process like withdrawal and other, medical issues. This can be translated across a lot of things, but we can treat them more quickly and help the body heal itself more quickly. Additionally, ICU and hospital stays are expensive. And financial burdens can really impact the stress level of both patients and families. And so by reducing that financial burden, we can reduce that stress on patients and families and promote healing and encourage them to find other resources that can help them in their journey for their alcohol use disorder. These are my references. I'd like to especially thank University of Chicago AdventHealth Hinsdale family medicine residents and faculty for their support. I'd additionally like to thank a lot the biostats team at Midwestern, notably Mr. Chase Irwin, who taught me what a negative binomial distribution means for statistical analysis and helping me with data analysis for this project. Any questions?
Oh, I imagine we will. Thank you so much for that presentation and for
Sure.
thanking your stats team. That's always important. All right, at this time, Doctors Lockhart and Montgomery, if you have any questions for Dr. Gorty, the floor is now yours.
I have a question. My question is, I guess it's two questions. The first one is there a protocol at these hospital and within this hospital system for when Precedex or dexmedetomidine, whatever, is instituted? Or is it just random? Like, how do the teams overall decide?
Yeah. So yeah, it took me like 7 presentations of doing this to say dexmedetomidine correctly. So I don't blame you for struggling through that. Precedex in our hospital system, the protocol is essentially that if there is after being on like a fixed taper of benzodiazepines, if there's still increasing agitation or CWA scores that aren't being controlled on the fixed taper alone, that they qualify for ICU admission for Precedex like Precedex drip. But that's as far as the protocol really goes. And so, you know, if you actually talk to like the addiction medicine docs that, and if you actually talk to units and hospitals that have like more addiction related units and nurses and doctors that are trained in that, they, you know, they don't use from what I've been told, they don't use Precedex as much, and they have treatment protocols for benzodiazepines to be used on top of these fixed tapers to be able to help with the withdrawal symptoms. And so you know, that's why we tried to keep those variables the same by taking a look at patients that had similar CWA scores that were going to be admitted to the ICU for both of those reasons, and those that were given Precedex and those that were given benzos, because they both had high CWA scores. And so while trying to account for, like I said, the similar intensity in CWA scores and trying to make that the same kind of across the board, is there a change with Precedex use versus benzos alone? So we did try to account for that in this research study the best that we could. But yeah, the protocol isn't very definitive for sure.
Okay, thank you. That clarified it quite a bit.
This is Dr. Montgomery. I wanted to ask one clarifying question and then a separate question. You had mentioned at the beginning that this was built upon a prior study. Can you just outline, you know, your role in the first study and then your role this time and like how they differ?
Yeah, sure. So I mean, I was me and a co-resident of mine that was a year like older, like so he graduated last year. We're the ones that kind of started this study together because we wanted to take a look at this project. And so last year, what we had done is we looked at 2 hospitals, just the Hinsdale and the LaGrange sites, which gave us an N number of like around 100. And so, you know, not as, you know, statistically significant because of a lower N value. And so this time around, I wanted to add the Bolingbrook Hospital to this data set. And that's pretty much the difference only between the last year's research project and this is the attempt to add more patient population to the data and seeing if that changes the results of the study with a higher N value. But in this case, it just made the results more statistically significant.
Got it. And then I wanted to follow up on what you were just saying about CWA and the role of kind of like other outcome measures in kind of balancing, because we're looking at length of stay, right? And we know length of stay has implications for other things, but I also wonder, was there a difference in sort of like more patient-oriented outcomes? For example, you were mentioning that the hospital protocol, if they're at a certain CWA level, then they are eligible for Precedex in the ICU. And then you tried to match patients based on CWA. Did you then continue to watch their CWA scores, you know, in the group that continued on, you know, just benzo alone versus benzo plus Precedex? Did you see any difference in average CWA scores in those groups throughout their hospital stay? So for instance, we can imagine they have a longer hospital stay, but maybe they have lower CWA scores, meaning less intense symptoms, over that longer period of time kind of thing.
Yeah. So because this was a retrospective chart review, we didn't take a look at kind of the CWA scores after the start of treatment, but we did kind of account for, like, at the start of treatment having like similar CWA scores, both of which, you know, having a certain level of like and a higher CWA scores was what qualified them to be admitted to the ICU in the first place, because there are patients that are on normal like the med surge floors that can go through the alcohol withdrawal taper and are absolutely fine. So you know, really it like that's why the inclusion criteria of needing to be admitted to the ICU was placed, and understanding like that the starting CWA scores for both of these patients were kind of similar. That being said, though, yeah, that is correct. That I think that for further analysis, taking a look at what the CWA scores are and how they go down for patients while they are on the Precedex versus not would be a good way to kind of further this data as well. But we in this study did not take a look at that.
Thank you.
Mm-hmm.
Thank you so much for that presentation, Dr. Gorty. And that brings us to our final presentation of this block. You can stop sharing your screen and I will welcome Dr. Faizan Master coming to us from the Jackson Park Family Medicine Residency Program. Reviewing his presentation will be Dr. Reese and Dr. Lockhart to bring us to the final presentation of this block. We can see your slides. If you can see if we can hear you.
Sure. Hi, good afternoon, everyone.
Gotcha. Okay, you'll have 15
all right.
minutes. The clock will begin when you do, and we wish you the best of luck.
Perfect. Thank you. Hi, good afternoon. I'm Dr. Master. I am a PGY3 resident, family medicine resident from Jackson Park Hospital, Chicago. And I wanted to do a study on basically exploring patient and physician perspectives on smoking cessation medications and their barriers. So basically, let's start with some introduction. So tobacco use is #1 preventable cause of morbidity and mortality in the US and worldwide. It's the leading cause of preventable disease, disability, death in US. About 1,600 people under 18 try their first cigarette, and about 200 of them become daily cigarette smokers. It causes more than 480,000 deaths annually. And this is basically cigarette smoking is costing the United States over $300 billion each year, just out of which $225 billion is direct medical costs. So when we look at tobacco cessation counseling, we look at it is one of the highest ranked services, but very low delivery rates. Like we would try to discuss it with a lot of patients, but the delivery rate is really low. However, let's go forward. And in 2018, approximately 34 million American adults smoked cigarettes, and out of which 68% of Americans who smoke would like to quit, and 44% of the patients who saw a provider did not receive smoking cessation advice, and 31% of patients who tried to quit using they used FDA-approved medications or counseling. Now, it is a chronic relapsing disorder, and we need to basically have long-term management goals and have an intensive treatment approach with the patients. So current USPSTF guidelines, we all know that it's a grade A recommendation that we should discuss tobacco use and advise people to stop using them, and even give them pharmacotherapy if they need any assistance in helping them. It's a grade I recommendation to discuss pharmacotherapy with pregnant patients, and it is insufficient to recommend any electronic nicotine delivery systems, and including for pregnant patients. So the US Public Health Service guideline recommends first-line drugs for cessation in all or most smokers who smoke at least 10 to 15 cigarettes a day. And clinical interventions as brief as like 3-minute interventions, like just discussing with the patient, really help increase the abstinence rates. And behavioral interventions, when combined with pharmacotherapy, have the best effects. When we look at different kinds of treatment options that we have on the table, we have nicotine replacement therapy, we have gum, we have lozenges, we have nasal sprays, we have inhalers, we have patches. All of these are nicotine replacement therapies. However, in addition to that, we have some pharmacotherapy, which is bupropion, we have Chantix or varenicline, and we have psychosocial therapy, behavioral therapy. However, when we look at the success rate of pharmacotherapy, we found like this is research by ACC and ATS, and they showed that varenicline is superior to any other smoking cessation medications, which includes the bupropion or the nicotine replacement therapy. So it reduces relapse rates, it improves recovery outcomes, and it is better for like extended duration of therapy. It keeps the patient off the nicotine for a longer period of time. So these are some comparison of guidelines by different societies. Now, from what I did, the qualitative part of my interviews with some of the physicians was showed that they were kind of hesitant about the psychiatric safety of varenicline, which has been demonstrated in 2016 Eagles trial, which showed that the varenicline and bupropion have no significant increase in psychiatric adverse events, regardless of baseline psychiatric conditions. So the FDA has already removed the black box warning for the increased risk of severe psychiatric events and suicidality with varenicline and bupropion, but physicians still seem to be a little hesitant about prescribing pharmacotherapy when it is needed for patients or when the patient requests for it. So basically, my objectives of my study was to explore patients' attitudes, example, acceptance, concerns, barriers, and beliefs regarding the use of medications, such as like the nicotine replacement therapy, the bupropion, or the varenicline. And the other side of my study was to assess the physicians' attitudes, like preferences for pharmacotherapy, hesitations regarding medications, prescribing habits. And I wanted to identify the most common barriers that affect both physicians and the patients in pursuing any smoking cessation pharmacotherapy, and to see if it works or not. So my method basically my method was a questionnaire. So it was a cross-sectional study. It is a cross-sectional study. It's a survey. I'm doing questionnaire-based surveys for physicians and for patients. I'm collecting data from patients who are current smokers and recent ex-smokers at Jackson Park Hospital Family Medicine Clinic, and I'm collecting data regarding their demographic data, including medical history, smoking history, nicotine dependence, which is assessed via the Strom test. I'm checking their past quit attempts. What did they use in those quit attempts? How long were they abstinent for when they tried to quit? Attitudes towards cessation medications and willingness to use them, and the knowledge of contraindications to smoking cessation medications. So I also went into detail regarding their hesitance to ask their primary care physician if they wanted any help regarding smoking cessation. And I found something that was very surprising, and that basically pointed me towards going towards like the other part of the study, which is basically asking physicians about their average patient encounters per day. How many percentage of patients did they provide with did they offer nicotine replacement therapy, bupropion or varenicline? How many percentage of patients were prescribed nicotine replacement therapy, bupropion or varenicline? And approximate percentage of patients who accepted the intervention successfully quit after accepting those interventions. So This data is currently being analyzed observationally to determine trends in physician and patient hesitance towards smoking cessation pharmacotherapy. My goal is to obtain about 75 patient questionnaires and 25 to 30 physician questionnaires for data analysis. And during this data analysis, I'm not including any inpatient in like admitted patients because that gives us a Bergson bias, and we are trying to and this study is still an ongoing. I think it's a much bigger study, and furthermore, more residents from my program are going to work on this. Target patient numbers and physician numbers are not achieved yet. So preliminary data from the 25 questionnaires that I got from patients, from the patients who agreed to consent for the study, is that patients who have household members or peers who continue to smoke pose a barrier to cessation attempts. 90% of the patients had peers or household members who smoke. Current smoking patterns, level of nicotine dependence, and backyard history are still being analyzed at this time. I'm looking at more patient numbers at this, I'm trying to collect more patient numbers before I try to analyze those. At this time, 20% of the patients never attempted quitting. However, 80% of the patients attempted quitting at least greater than one time in their lifetime. And quitting cold turkey was associated with 80% of the cessation attempts. Nicotine replacement therapy was associated with 60% of the cessation attempts. 50% of the patients were able to be abstinent for a period of greater than 12 weeks at their cessation attempts. And 100% of the patients relapsed more than 12 weeks later. So the relapse rate, looking at this data, it shows that a lot of patients are comfortable with nicotine replacement therapy and quitting cold turkey, but the relapse rate with those methods is very high. Pharmacotherapy as a method of cessation was associated with only 5% of the patients, and we are still working on the data, on collecting the data and getting to the target patient numbers. 90% of the patients who consented to the study had a Fagerstrom dependence score of 5 to 7, which shows that it is moderate to high dependence. And 90% of the patients discussed smoking cessation at least once with their PCP in their life. And out of these patients, 20% were provided counseling for cessation without any nicotine replacement therapy. And 80% were provided with nicotine replacement therapy along with counseling. 8% of the patients were informed of pharmacological options, and 4% were prescribed during their encounters. So we can see how the numbers are trickling down. So we saw that there are a lot of, out of all the patients, out of all the patients who are participating in the study, a lot of patients were provided with nicotine replacement therapy, although we know that the relapse rate with nicotine replacement therapy is pretty high. And only about 8% of the only 8% of the patients were informed of the pharmacological options, and 4% were prescribed, which is a pretty low number, considering the fact that pharmacological options are pretty pharmacological options show a pretty good rate of cessation. So basically, 75% of the patients never followed up about their attempted cessation and abstinence or relapse again with the PCPs. So they relapsed and never discussed it with their PCPs again. Now, this is regarding the physician questionnaires. So I collected data from about 10 physicians at this point. I'm still in the process of collecting more. Primary care physicians and residents aged 25 to 70 were included for this questionnaire-based survey. And 100% of the physicians work in traditional family medicine physician role, which is outpatient and inpatient, and average patient encounters per day for each physician ranged from 8 to 15. Preliminary survey showed about 50 to 90% of the patients under the care of these physicians are nicotine dependent. And out of these, only 50% of the patients who are nicotine dependent were offered were offered any prescriptions. I'm sorry, were offered nicotine replacement therapy, and only 50% of the offers resulted in a prescription being sent. So a lot of patients were offered to be prescribed like nicotine gum, lozenges, or patches, but only 50% of the patients actually wanted to accept those prescriptions. However, physicians were offered varenicline to about 0 to 10% of the patients, and prescriptions were sent for even a lower number, for 0 to 2%. Physicians offered bupropion to 0 to 50% of the patients, and prescriptions were sent for 0 to 20% of the patients. And the years of practice for each physician correlated inversely with the hesitancy of prescribing pharmacotherapy. So keep in mind that I'm trying to get data from physicians who are still in training, and there are physicians who have about 30-40 years of experience. An average of 5% of the entire nicotine-dependent patient population ended up quitting smoking as a result of counseling, nicotine replacement therapy, bupropion, or varenicline. So, according to the data that I collected, I find that the common barriers that the physicians face in decreasing frequency are: one is patient compliance. A lot of patients didn't come back and never talk to their primary care physicians ever again about nicotine replacement therapy or quitting again. And a lot of times the physicians, due to time constraints, do not talk about smoking cessation or the methods of quitting. The second common barrier was cost or insurance issues, insurance coverage. Third was time constraints during visits. Fourth was patient motivation. Fifth was comorbidities. And sixth was physician education or hesitancy with respect to contraindications or monitoring protocols. Limitation of the studies, estimates and approximates of the data from the physicians are used, which can create recall bias and reporting bias, and there is also a possibility of reporting bias from the patients who consented for the study due to perceived social stigmatization. Due to EHR limitations, we could not get the exact numbers from the physician data.
Thanks to you, Dr. Master. We've hit your 15-minute mark, so leave that slide up there for us. Actually, I'll go ahead and read off to you a question from Dr. Lockhart that she submitted to the chat. It's regarding the physician attitudes. You stated that you were assessing their attitudes. Did you ask about questions about their attitudes towards the treatments, NRT and pharmacological treatments?
So that's a very good question. Yeah, the topic is regarding attitudes, but I did not ask about their attitudes or their perception of the treatment. Rather than that, I was looking at the objective measures of it, and looking at the objective measures, meaning I was looking at the number of patients they see who are nicotine dependent, the number of patients they prescribe the medication to, number of patients they discuss smoking cessation with. So I think my perception of the word attitudes was more objective rather than qualitative. So I was trying to do a quantitative cross-sectional, and the qualitative part was not there. Yes.
And Dr. Reese also submitted a question via the chat. First, she says, great topic. She asked if you have a tentative plan on how you are going to educate patients, whether it's handouts, other resources, group visits, about their options based on your research results.
So I think there is a multi-pronged approach to this question, which I would like to do. Is one thing, I would like to approach this topic from both ends, at the physician end as well as the patient end. So from the patient end, I can see that patients are not aware that there are medications available in the market for them to help quit. And I think they need to be made more aware by putting out posters in the waiting area, which can at least trigger a thought for them to just ask their physician, okay, I saw a poster in the waiting area about some medication for quitting to smoke, like for quitting. How can I avail that service. And the other thing would be, I think, would be educating more physicians about addressing the barriers that they face or that they feel about not prescribing. So one would be patient compliance, second is patient motivation, third is hesitancy. So I think hesitancy needs to be removed with education. I think education and training for the residents and the physicians is in my plans. Yes. Thank
And
you.
then just one question for clarification. Was your data collection solely on combustible traditional cigarette use, or did it include other nicotine dependents such as electronic cigarettes or hookah?
Yes, sorry, I forgot to mention that in the methods. Yes, my study was completely based on patients who are using combustible cigarettes. I did include patients who are currently also smoking cigars, which has a different so that's why I couldn't get their accurate smoking history. But yes, I did include patients who are currently smoking combustible cigarettes and not on electronic nicotine delivery systems.
Great, thank you for that answer. If Dr. Reese or Dr. Montgomery have any other questions, we have another minute. Otherwise, thank you so much for that presentation.
Sure, thank you.
All right, I don't hear or see anything from them. So with that, I'd like to thank all 6 of our presenters, as well as our 4 guest reviewers. So what happens next is our reviewers will submit their scores and comments to me, and I'll compile all of them and send to each individual lead presenter their scores and comments by tomorrow. And this recording will also be shared with the presenters, and eventually will live on our IAFP YouTube channel. So that's it for this block. We have 1 more block and 2 more presentations coming up at 4:20. And we hope that all of you will join us then. Enjoy a quick 20-minute break to regroup for our final presentations of the afternoon.
Thank you.
Okay, we're going to go ahead and get started with the final block of today. Welcome back to the last block of the Resident Scholarly Works Virtual Summit hosted by IAFP. We have 2 presentations to go, so we're going to go ahead and get started. Just a reminder that IAFP supports diversity, equity, inclusion in all its forms, and that we also hope today's activity reflects our commitment to those values, activities, and behaviors. Everyone is in listen-only mode, and today's webinar has been recorded and will be made available on the IAFP's YouTube channel. Only our anonymous reviewers will be able to ask questions, and those questions and answers will also be part of the recording. As we are offering CME credit for this presentation, we do need to know that the presenters have completed and submitted faculty disclosure agreements. It's our policy to adhere to ACCME and AMA conflict of interest policies. And I'd like to report that for this presentation, neither Dr. Campos-Munoz, Dr. Memedovsky, or myself reported any relevant financial relationship or interest with a proprietary entity producing, marketing, reselling, or distributing healthcare goods and services. That being said, you can claim CME credit for every presentation that you view today. There were 14 total. I'm probably the only one who saw all 14. For those of you who are watching live, you will be able to use the link in the chat and will be sent out again and also by email tomorrow. You can claim credit for each presentation that you watched, and then you'll be able to download your certificate upon submitting that. For those of you who are watching the recording online, if you go underneath the video to the description, click on more, it will provide the rest of the text, which will include the link to the post test that you can submit for your own CME credit there. A couple of upcoming events, just our annual foundation fundraiser. This will be our 2nd year going back to the Chicago Sky Game. This is easily found on our website, and you can purchase your tickets directly. For all of our presenters, we hope you will submit your presentation as an abstract for Family Medicine Midwest, which will be in Naperville this year, so in September. The call for abstracts is open and closes June 1st. There's the website, fmmidwest.org. And again, that deadline is June 1st and cannot be extended. And then also, we hope that you will review today's events and your interactions with the Academy on Google. You will get this link also in tomorrow's follow-up email, and there's a QR code there. So how does this work? Each presenting resident will have 15 minutes. There'll be a 2-minute warning in the chat, and if you hit your 15 minutes, I'll ask you to wrap it up, and then our anonymous reviewers will pose their questions either in the chat or they can unmute verbally. What's at stake besides your bragging rights? There are gift cards for the top scoring presentation in the completed works and the research in progress categories. So with that, I'm going to stop sharing and welcome to the first of our final two presenters. We have our two guest reviewers, which are Dr. Natalie Manning is back, and Dr. Elizabeth Corday has joined us to help review and ask some questions. Our first presenter for this block is Dr. Alejandro Campos Munoz, coming to us from the St. Mary and Elizabeth Medical Center program in Chicago with his completed project. Dr. Munoz, you can unmute and share your screen. And then once we've got you, see you and hear you, then the clock will begin when you do, and we wish you the best of luck.
Thank you, Dr. Flynn. I will start sharing my presentation. And I'm just wondering if you're able to see it now.
We've got it in presenter mode. There you go. Good luck to you.
Perfect. Thank you. Hi, everyone. So this is one of my research projects. This is garlic as an integrated therapy for patients with type 2 diabetes mellitus. And this is going to be a review. And first of all, why garlic and why type 2 diabetes? So the relevance of this is that in the US, according to the last statistics in 2021, diabetes was present in almost 15% of the population, and for prediabetes, almost 40%. So these are very high numbers. So this is a very, very common disease. And people who have diabetes have an annual medical expenditure of about $12,000 per year, which is 2.6 times higher than people without diabetes. Saying that, this means that people are spending much more money. And one important statistic here is that 1 of 3 adults report using complementary medicine in a survey done in 2022. And the more medical problems people have, the more they will start getting or using complementary medicine. So with this relevance, I decided to take a look a little bit more into garlic and if it is helpful in diabetes. So garlic, it's the Latin name is called Allium sativum, which is related to the family of onions, shallots, and leeks and chives. It is originally from Central Asia, but now we know that it's all over the world, especially for cooking purposes. However, this plant and this food, I would say, has been referenced in so many ancient medical texts from Egypt all the way around to Rome and China with many medical benefits. To learn a little bit more about garlic and its components, I wanted to put this diagram or this image where I'm showing you how fresh garlic and cutting it starts a reaction process of one of the most important components of the garlic, which is the allicin. And allicin gets rapidly transformed to allicin, which has the main therapeutic effect on, we'll see what are the different targets that we can find or the benefits for garlic. And we have other components called sulfides, adjuvants, vinylidene that as well have certain benefits to the health in humans. And there are plenty of components along with vitamins and minerals that garlic can provide. However, it would depend of the amount of the molecules and the specific benefits that will apply to the human body. In this next slide, I'm gonna show you like some of the things that we can find in garlic, some of the formulations. So if we have the garlic and we leave the garlic into a stable temperature and leave it there for a certain amount of time, then we will get something called aged garlic that has specific components that we cannot find in regular fresh garlic. On the other hand, if we see on the part where there's an alcohol molecule, if we soak the garlic in alcohol, we can get an extract, and we can use the extract, or if we leave it for more time, then we will get an aged extract. Other ways on how to use garlic would be if we use distillation process where we can get oil, and this will get some different components from garlic, and this oil then we can encapsulate it and put it in a capsule. So other forms could be powder. If we dehydrate the garlic, we can create a powder and potentially create a tablet. And we can have as well some versions of raw garlic. In this next slide, I'm showing you how the different presentations or formulations of garlic can have very different components. And we'll see in my next slides that the therapeutic effects would depend on the quantity of those molecules and the diversity of those molecules. But as you can tell on the garlic homogenate, we have allicin, and allicin and allin are represented in most of these formulations. This is a paper that is showing us what are the different benefits that we can find in humans. Some of them have been more in vitro studies, but most of them have had at least some trials in humans. And we'll see that on the bottom right, it has some anti-diabetic effects, and as well on your left side, some cholesterol lowering effects, and some anti-metabolic disorders, which could potentially be of some benefit for people with diabetes. So having this inner background, like knowing that garlic could be a potential tool, I started looking more into having a question for this research project, and this question was, is garlic useful in the management of patients with type 2 diabetes? So to answer that question, my hypothesis was that yes, I think garlic could be a useful alternative treatment option for patients with diabetes. And the methodology that I use, I went on to PubMed, and with the terms of garlic and diabetes, I performed this search as of May 8th, and I found about 400 articles. Of these 400 articles, 163 were in humans, so a decent amount of articles. Most of them were reviews, but 11 were randomized clinical trials. And I wanted to see if there were any systematic reviews or any meta-analysis on this topic. And I found two articles. One was a systematic review with a meta-analysis, and the other one was just a meta-analysis. So these are one of the strongest studies that we have for reviewing the quality and efficacy of some medications. So I'm going to describe very briefly these two systematic reviews and meta-analysis. The first one, the aim was to investigate the effect of garlic on lipid parameters and serum glucose in patients with diabetes. And they did a research on this different research machines, including some from Iran, because this study was published in Iran, and it was published in the Primary Care Diabetes Europe. And the languages that they used was English and Persian. and the dates were from 1988 to 2016. They found 33 studies in this systematic review. They chose experimental studies, and they were able to gather at least 1,273 patients. Study durations of each of those studies were from 2 days to 180 days, which is almost 6 months. And the garlic dosage that they used was 500 milligrams to almost 20,000 milligrams. Some of the main findings was that the blue bubbles that you will see there are the experimental group versus the yellow bubbles, which are the control groups. On the experimental groups, we see that people who were exposed to garlic had a reduction in total cholesterol. It's here minus 16.8. And down here, I'm putting the confidence interval, which were 95% confidence interval, and the p-value of all these results were less than 0.001, which that means that we have a significant reduction not only in total cholesterol, but as well in triglycerides and fasting blood glucose, compared to the controls that we have in the yellow bubbles. When moving into the discussion of that article, they didn't mention what was the garlic preparation that they use in these articles. Of the 33 studies that they have, only 10 were randomized clinical trials. So they didn't follow, most of these articles didn't follow a very strict rules for searching or for trying this this garlic in patients with diabetes. The studies were comparing the studies that were comparing garlic plus hypoglycemic agents were excluded from this systematic review. They didn't mention as well the quality of the studies that they selected. And one of the good things is that they were able to assess the bias of publication of those articles that they selected. And it seems that they have a low risk of bias, at least for the lipid panel outcomes, and moderate risk for the fasting blood glucose outcomes. Then moving on the next meta-analysis, which is our last one. This meta-analysis was from a group in China. The aim was to evaluate the clinical efficacy and safety of garlic supplement in the management of type 2 diabetes mellitus. The searching engines that they used was PubMed, Embase, Cochrane, and the China National Knowledge Internet. The languages that they used were English and Chinese, and they pulled all the articles that were available until 2017. The results that they found is that they found 9 studies, and of those 9, all of them were randomized clinical trials. They gathered almost 1,000 patients, and the study duration was 14 days to 168 days, which is almost as well 6 months. And the garlic dosage that they used was 50 milligrams to 1,500 milligrams. And they only selected the articles that were using powdered tablets. Here are some of the results for the A1C, glycated hemoglobin. So at 12 weeks, they were able to see a reduction of 6.93 millimoles per liter, which that would translate to a 2.78% of the A1C with a significant p-value. And in 24 weeks, there was a higher decrease in the A1C of up to 13.25, which would be 3.36%. Then if you take a look closer where it says I square, and next to 12 weeks, we have the number of patients in the garlic group and the number of patients in the control group, which were 180 and 180, then the 98% that it's here, it's telling us the heterogeneity of the studies. So the 9 studies that they selected, we see that they have a very high heterogeneity between those groups. And that would be important in our discussion that I will comment in a couple of slides. Then the results for the cholesterol, we see that the cholesterol in 1 to 2 weeks, there was no significant difference when using garlic. And 3 to 4 weeks was the same, no significant difference between groups. But then at 12 weeks, we see that there's a significant difference when patients were exposed to garlic. There was a significant reduction of 73.5 milligrams per deciliter, which is quite impressive. On the other hand, we have LDL, which is the low density lipoprotein. Similar findings on 1 to 2 weeks and 3 to 4 weeks, we didn't see any reduction of this type of cholesterol when people were taking garlic. However, when they were using it for over 12 weeks, we see that they have an important reduction of 3.47 millimoles, which that would translate to 134 milligrams per deciliter. In regards of safety, this study tried to assess as well if it was safe to take garlic. So the two adverse reactions that were reported were heartburn and indigestion. Heartburn was only mentioned in 3 trials, and the number of cases in the exposed group was 5, and the control group was 0. And indigestion, 1 trial only reported indigestion, and the number of cases that were reported were only 2, and 1 in the control group. So that gives us a relative risk of 1.96. However, if we see the confidence interval, it crosses the number 1. That means that there are no significant difference in patients that are taking garlic compared to the patients that are taking placebo.
Dr. Campos-Munoz, your 15 minutes have passed. So you can put your next slide up, and perhaps when our 2 reviewers ask you their questions, that may allow you to address the remaining slides. So I will turn the floor over to Drs. Manning and Corday to ask any questions of Dr. Campos-Munoz.
Perfect.
And again, you can unmute and ask your question verbally, or you can put it into the chat.
Good afternoon. Thanks for presenting on this topic. I learned a lot from the presentation. I'm curious to know what spurred you into this, interest area. Why garlic, and what do you plan to do with the information that you have discovered in this review?
Thank you very much. Yeah, so the main reason was some of my patients were already mentioning to me that garlic, that they heard that garlic could be good for lowering their sugars. And I was very intrigued because that happened a couple of times during my residency. And I didn't know what to tell them. I was like, well, sure, I didn't know. And then I did an integrative medicine rotation in the University of Arizona, and they were teaching us, how to look for information and try to, present some of this alternative medicine to our patients. So I decided to choose garlic. And I think answering your last question, like how would I if I would integrate it into my practice, or what am I going to do with this? I think this on my final takeaway, as rates of type 2 diabetes continue to increase, I personally could use garlic as an integrated therapy since there is moderate quality evidence of its efficacy and a low risk of harm with its use.
I can tell you I'm actually hungry now after all this talk of garlic. Dr. Manning, do you have any questions that you'd like to ask?
Yes, thank you. I think it's a very interesting critical appraisal of your best quality evidence, and I appreciate your knowledge and thinking about and discussing it, including your heterogeneity quotients there. Why do you think the dose varies so much? And what are your thoughts about that? And were any of the studies have any analysis around the dosage itself making, correlating or not correlating with the outcomes?
Yeah, so I think the heterogeneity comes a lot, as in this second point that I'm stating here. It comes a lot on the preparation that it's coming, garlic, the dose that they're using, and the duration. We see that some articles were like just a couple of days. They were trying to check fasting blood glucose after patients being taking it for just a couple of days, and then some studies were like 6 months. So I think the heterogeneity comes into play because the dose, we're seeing doses from 50 milligrams to 20,000 milligrams. So I think it's difficult to compare those parts. And as well as I was mentioning, the different preparations of garlic, they differ a lot on their components that they have. So I'm assuming there must be something in the type of garlic preparation on the effect that we're seeing on the lipids or on the glucose. They did not mention how to compensate this heterogeneity, but on their analysis, they mentioned that I think I put it here. They did a random effects model compared to a fixed effect model, which that would overcome some of the situation with the heterogeneity. But I think a lot what they mention at the end is we need more research on the optimal preparation and the dose for garlic. And my final point, it is that the US is the main country who can contribute to research. However, most of the research on garlic is mainly from overseas and from places that it used to be a traditional medicine. So I think it would be a good point to, to move in the US to start looking for, to start studying it more.
I agree with you. If your cousin asks you though, how much garlic they should take every day if they have pre-diabetes, what are you going to tell them? I know that's unfair.
Yeah. And as well, there are garlic supplements which are very well standardized, and the problem comes on the dosing. Like even though we have really good quality of garlic supplements, we don't know the dose. So that's as well another caveat.
Thank you. I hope you submit for Family Medicine Midwest because I think it's very intriguing discussion.
Thank you.
Thanks so much, Dr. Campos Munoz. And that brings us to our final presentation of the afternoon. You can go ahead and stop sharing your screen. And if Dr. Zilfi Memedowski would please share your screen, we will bring this little webinar home. Dr. Zilfi Memedowski joins us from the Hinsdale Family Medicine Residency Program with a completed project to present this afternoon. Let's see if we can see you and hear you, and we'll wait to see your slides. Just a reminder, you'll have 15 minutes to present your program. I will give you a 2-minute warning in the chat, and if you hit 15 minutes, you'll hear my little phone timer go off, and I'll ask you to wrap it up.
No worries, thank you. Just give me 1 second here. Hopefully you can hear me.
Can hear you, can see you.
I have my option to share right now grayed out. So let's see if I can get that issue resolved. Perfect. Okay, can you see my screen right now?
It looks like it's on the way, and there you go. Whenever you're ready, the timer will begin when you do. Good luck to you.
Thank you so much. And I will just get ahead, get right on it then. So my name is Zilfi Mehmedovsky. I have a very long presentation name here, but this regarding the research I did. It is the evaluation of resuscitative efforts on patients' cardiopulmonary arrest regarding co-duration and all-cause mortality with a comparison between AdventHealth Great Lake Region campuses. So, a little disclosure, if you can't tell already, I am a resident associated with University of Chicago Medicine and AdventHealth. This study, I don't have anything to disclose other than that. I have no financial or personal relationships or benefits that I received to disclose. So just to give a very brief background, as I'm sure everyone here is aware of, regarding what cardiac arrest is. I mean, it is the sudden loss of all heart activity. Typically, this is something that, all interns and all recent med school graduates always dread because it's such a high pressure situation to be involved in. Typically, we have the standard ACLS protocol that's followed, and a key component of that protocol is just following it is, to the letter, and that it is what allows us to help achieve ROS, hopefully for patients. And it really is just dependent on taking the appropriate steps as soon as possible. Now, because of how important and critical ACLS protocol is in regards to resuscitating patients that we are able to save, it is important to understand that the ability to effectively respond is critical. Resident doctors are, a group who are, confidence is usually a little bit lower handling these situations. They don't have the experience. And part of my research and why I felt like it was necessary to, look into this was just to see if we have differences in outcomes between resident run and attending run codes, as well as seeing what are the ultimate outcomes for our patients. Because as we know, outcomes are what are most important. We want to be seeing good outcomes for all patients. All right, and then just one other brief thing. Being a DO, it's always important for me, at least, I'm sure for everyone else as well, to kind of help think about how our study, not just our research, but also what we do as physicians, is helping out patients and making sure we're doing what's best for them. For my study in particular, hopefully this information here today, it's probably just going to reinforce some stuff you guys already know, but it should help kind of continue to help us provide the appropriate information and background knowledge that we need to help provide the best advice to our patients when it comes to discussing things such as code status, hopefully in an outpatient setting and not during a sudden cardiac arrest while they're hospitalized. All right, so for my study, we had several key objectives. We were evaluating the correlation between code duration and cardiac arrest and all-cause mortality. We were looking for a relationship between pre-existing risk factors and patient characteristics of mortality during a code, and then as well as assessing patient outcomes and discharge of disposition for those who we were able to get ROSC on. And then also the extra addition to this study for me was the comparison of metrics between residents and attendings RAN codes. All right, and then regarding how this study was actually performed, it is a retrospective correlation study. There was a 2-sample t-test analysis performed to assess duration of codes. There was then chi-square analysis used of qualitative measures of patient outcomes. Then also comparison of the patient outcomes in resident and attending run codes via chi-square analysis. All right, and then just regarding the patient population that we were looking at in my study, we included patients at the age of 18 or older who had cardiac arrest during hospitalization. These were patients on the medical, surgical floors, PCU, or ICU between 2019 and 2022. So as you can see, we're excluding anything from an outpatient perspective, or if patients had come in for an outpatient procedure or the ED. And then we had, for our exclusions, resuscitative efforts that were started initially and then stopped due to a DNR status, resulting in the code duration being less than 20 minutes were not included. And then resuscitative efforts stopped prior to 10 minutes due to surrogate decision were also not included to the study. And then any patients that were unable to assess code duration through review of the medical record were not included as well. All right, so with all that covered in terms of how the study was done and our statistical analysis, so this is the first primary result I would just like to go over with everyone. So on the left of the screen, we can see our resident run outcomes is our primary outcome. So just a little bit underneath 60% of patients who had residents running their code survived and we achieved ROSC. When we see a similar outcome with around just a little over 62% of the patients achieving ROSC and attending RAN outcomes. So we had a p-value above 0.05, showing that there was not a significant statistical difference there. Now, the next question, of course, I'm sure is that's on everyone's mind is what happens once we are able to achieve ROSC. So for resident run codes and the attending RAN codes, our outcomes following achievement of ROSC are essentially the same. Majority of those patients, the largest section of those patients either go on to hospice or get switched to a DNR status or have a subsequent arrest where we are not able to achieve ROSC. Overall, we get a small subset of patients who are we able to be discharged from the hospital, whether it be to LTAC, a SNF facility, or go through acute rehab. And as you can see, we have a very small population that do end up being able to go home following discharge from the hospital. Now, when we're looking at the duration of codes in patients who do survive, we don't see a statistical difference between the means between both resident and attending RAN codes. Approximately for codes that were run by attendings and when we achieve ROSC, those codes last typically a little bit over 12 minutes, whereas residents are just under 10. And then as you can see, we do have a good amount of variability there with some of these dots you see above being codes that ran for very long periods of time. But as you can see, overall, our mean stays pretty close to one another. Now, for patients in which we do not achieve ROSC, as you can see, our average there is pretty close overall. Residents running a code just under 24 minutes on average, and attendings running the codes a little under 26 minutes. But overall, as you can see, on average, our patients who we are not able to achieve ROSC on, their codes last for over 20 minutes typically. And then when we compare our timings between patients that expired and patients that survived, or I guess we should say achieved ROSC, this information here is not specifically comparing resident to attending. This is more pooled information, but looking at the total amount of patients that we achieve ROSC on compared to those who we are not able to achieve ROSC, we see a stark difference between the times with that average code for duration for patients that do achieve ROSC being at around 10.5 minutes, and then being as opposed to our expired patients who are just a little bit under 24.5 minutes in terms of how long their codes run. And then this is a histogram here that just really kind of helps provide a visual representation to really hammer home the point. But typically, we're about 87% of all patients who we are able to achieve ROSC on. This occurs under 20 minutes. There is, as you can see, a chance that we can achieve ROSC in patients whose codes go over 20 minutes, but overall, that's not anywhere really near significant, as significant a number total as compared to those with much shorter duration of codes. All right. Now, another thing that we look at regarding outcomes, when we look at these outcomes based on age, we don't really see a difference in terms of total outcomes that occurred just based on age. So whether we have younger patients that are less than 50 or patients that are 85 plus, overall, we're getting roughly around that 60% rate of ROSC during of the patient population that we looked at in this study, with 40% not having ROSC achieved. And I don't have any graphs otherwise showing this, but overall, we see similar outcomes in terms of where they're ending up after being discharged from the hospital. So overall, what are our big take-home points regarding this study and what conclusions can we run? So there's no significant difference in the primary outcomes of the codes run based on who's running it, whether it be a resident or attending physician. There's no significant difference in outcomes following cardiac arrest for patients who achieve ROSC, regardless of the campus or the provider who is running the code. Codes are run for roughly a similar duration of time in situations, regardless of whether or not we achieve ROSC or we do not achieve ROSC for these patients. And duration of codes is significantly different between patients who survive and expire across both campuses in which this study was done. And duration numbers reflect that. Other things that we can take away from this, there's no difference in the outcomes based on patient age. There's no difference in the primary outcome based on initial rhythm. There were significantly fewer codes, and this is just a little caveat here, but of codes with VFib or VTAC, which are documented at Bolingbrook Hospital as opposed to Hinsdale, which is the Hinsdale Hospital being the one that has primarily resident run codes. At Bolingbrook, acidosis and prior CPR being administered, as well as vasopressor use and kidney failure, were all shown to have impact on survival outcomes, those usually being indicators of poor outcomes or less likelihood to survive. Whereas at Hinsdale Hospital, the only factor that cause of mortality that we had observed being something that had an impact on survival outcomes had been IV drug use prior to admission to the hospital. All right, so here's the big thing. Now that we kind of got a conclusion, just to kind of briefly talk about why do we care. Really ultimately what this comes down to is being able to properly and advise not just our patients, but also physicians, just kind of give that additional, reinforcement that like after about 20 minutes, it's fair to say there's a very low likelihood that patients are going to be able to achieve ROSC on these patients who do arrest. For the most part, if a patient is sick enough to be going into cardiac arrest, odds are they're not going to have a great outcome, even if we are able to achieve ROSC. So ideally, what this means for physicians in the outpatient settings that we should really be taking the effort to talk about advanced directives as well as what a patient's preferred code status is and making sure they fully understand not just what the code is or what CPR looks like, but also what the likely outcomes are. So while we might not always typically think about that for our younger patients, we should definitely be talking about that with our older patients. I'm sure most everyone here who has gone through residency have had elderly patients who wish to be full code, despite being in very critical status with poor chance of achieving ROSC. If it did come to a point where they would have a cardiac arrest, and that just leading to traumatic moments in which a family member is called late at night, being informed that we've had a code that's gone for 20 minutes on or longer at times, and having that hard conversation about whether or not they would want the arrest to be terminated. I'm sorry, not the arrest, the resuscitated efforts to be terminated. So, and then also just another caveat here, just making sure that really the most important thing in terms of running codes is that it's more so about the training and following the appropriate ACLS protocol. That seems to be a more important factor than necessarily the experience of the physician running the codes. All right, these were just some references I had based, but overall, that's all I have for right now. Be happy to answer any questions anyone has regarding the information that I just discussed there.
Thanks for
Thank
sharing.
you so much, Dr. Memedowski. Sounds like Dr. Corday has already got a question teed up for you. Go ahead.
I'm just wondering about the N, and I might have missed it, but how many codes are we talking about in these groups?
Oh, that's fair. Sorry. So in terms of the first group for resident run codes, the number was around, I believe, 278. The attending run codes was at Bolingbrook Hospital. That ended up being about 104. So both ends were above 100.
Wow. And how do you plan to disseminate this?
Well,
are you going to share it with others?
Well, that's a great question. So in terms of dissemination, that would probably moving we're trying to with a publication. One of the residents who had previously started the project, I think he might have submitted that already, but this is kind of like building on top of that. So in terms of that, that would be probably in terms of the best way I would think would probably seeing if, making sure the study is up to snuff for publication and kind of maybe pursuing that avenue.
Yeah, I think this is really, oftentimes I think residents are, feel like they're not going to be as good as the attending, right? And
right.
This really, I think, is good information for them to understand that, they have it, they can do this, and I hope you'll share it in other venues or in publication.
Thank you. And then one thing I would say is I hope that when that does come to that point where we're able to share it, it kind of helps give them that confidence that once they're hitting that 20-minute mark, they understand the odds of any really good outcome, even if they do achieve ROSC, is very low. Okay. Was there any other questions I can answer for anyone?
Yes, thank you. It's Dr. Manning. I agree with Dr. Corday that it is a good study. I believe I did hear the earlier study version last year. What was your role and how did it change the study before you started in it?
Okay. So the earlier study, that was more so they only looked at one campus. This study, we were able to expand the information that was used to another hospital campus. So in terms of my role, I was doing pretty much the analysis for everyone, all patients in the Bolingbrook campus, and just compiling that information. So pretty similar to how it was done, pretty much the same way it was done for the previous study. without no real difference. The only difference was just like the campus really. And then adding on top of that, just doing additional analysis where comparing the information total that was gathered at Bolingbrook to compare it to Hinsdale's campus and just kind of see what differences we saw pop up.
Thank you. When you talk about resident-run codes, my experience is that there's usually an attending there too. Is that true of the resident-run codes that you were analyzing?
So for our hospital, that is not usually the case. It's hard for me to verify for all the codes at Hinsdale if there was an attending present up on. At the typical code at our hospital is almost entirely resident run. There are occasions where we do have the attending present, but that is not always the case.
Good. And finally, why do you think it looked like subsequent arrest was higher in the resident codes? And even though the overalls were looking similar, that seemed to be dramatically different. Can you comment on that?
Yeah, so that's something that definitely, could be looked into more. It's hard to, I would probably have to do a lot more in terms of analysis to assess if those were patients that were either more critically ill or what their specific location was in the hospital, to be able to probably give the best, response to that question. Overall, I can't really attribute anything that's a clear-cut answer as to why it seems that, we had a higher amount of subsequent arrests in those resident run codes. But overall, that would require probably a little bit more analysis to see if there was a specific, trend, or whether that trend being whether those patients had more, more comorbid conditions, or what they were just like already in poor status to begin with.
Good, thank you. Sorry, one more, two more quick questions.
Yeah,
one is, how did your times and survival rates compare to national norms or other history norms?
Great question. So, not that I've done the most, not that I've been able to look at every national study, but they didn't seem to have differed too significantly from national norms. I think if I recall correctly, the total percentage might have been somewhat lower, but without being able to do a full statistical analysis, I wouldn't know if that's significantly different, but I think the survival rate was slightly lower. I believe nationally it was a little bit higher up, whereas we were kind of like 62, 61%. I think nationally it might have been about 64 to 66, but I don't know exactly like if in terms of those codes that are being documented, whether or not whether it's like using the exact same parameters, or if they are also including different patient populations, like patients in the ED or patients in pediatrics.
Thank you. And when you said IV drug use was associated with change in outcomes, did it make it worse or did it make it better because they were younger, or part of it was opioid?
Yeah, so great question. So regarding the IV drug use, that was something that was seen to lead to worse outcomes.
Okay.
This area, I think we have a little bit higher propensity, or at least the patients, where IV drug use is more prevalent. So that was I think that was well documented in these cases. And we had like a decent enough N. I think the N nowhere near, like it's not in the hundreds like it was like the total population that I looked at, but I think we definitely had around, I think, 15 cases to make at least get enough of an N number, around 15, like I said, to get a decent enough idea to see if it had an effect.
Thank you. And I do hope you disseminate it too, both in publication and maybe with your previous co-authors on this study, present it to residents about how to do good research. Thank you.
Thank you so much.
I'll add my thanks as well, Dr. Mamedowski. That brings us to the close. Thank you so much, and make sure everyone submits those abstracts for Family Medicine Midwest. We had some really great presentations today. My thanks to all 14 of our presenters and their co-presenters, and to our volunteer reviewers in this block. That was Dr. Manning and Dr. Corday. And they all come from the IAFP's Family Medicine Educators Committee. So thank you so much for your time and support of this event for 13 years now. We were doing virtual summits before COVID and before Zoom became a thing. So thank you so much. That concludes today's. Our reviewers will submit their scores and comments to me. I'll be compiling them all tomorrow. And then each lead presenter will receive their scores and their comments individually and privately. And the recording of this event will be posted on the IAFP's YouTube channel and sent out to all of our attendees by email tomorrow. Thanks so much, everyone. Have a great afternoon and evening, and thanks for participating.